are beginning with our today's first session. Okay, so this is session 5. I would like to welcome our chairperson, Dr. N. Suresh Kumar. He is the assistant professor and clinical psychologist, Department of Psychiatry, Government Rajaji Hospital, Madurai Medical College. He has completed MPhil in clinical psychology and PhD in neuropsychology from Vatiyar University. His areas of interest are clinical neuropsychology, psychological assessment, learning disability and remediation, behavior therapy, innovative research in clinical psychology. Sir is the member of Tamil Nadu State Mental Health Authority, founder secretary CPSI and secretary TNSEP. Welcome, sir. Now I would like to welcome our second chairperson, Mr. Akashdeep Ghoshal. He's an assistant professor of clinical psychology at IBHAS, Amity University. He has an experience of 10 years and his areas of interest are in psychiatry and neuropsychology. I would like to request our director, ma'am, to felicitate Dr. N. Suresh Kumar. Requesting also ma'am to felicitate Akash. Okay, so we are beginning with our first presentation. Participant Inchara is present. Yes, please come.
Good morning, all. Yes, good morning, all. I'm Inchara S, research scholar from Department of Psych. Okay. Good morning, all. I'm Inchara S. Yes, I'm Inchara S, research scholar from Department of Psychiatry, Kasturba Medical College, Mangalore, and I come from a Mahe University, Manipal, and my co-authors are Anaga S and Dr. Keshav Pai K. My title of the study is Tobacco and Alcohol Uses a Comorbid Addiction. So coming to introduction, alcohol use disorders is a widespread public health concern worldwide, leading to substantial illness and death. It's striking how epidemiologically and clinical research consistently show that individuals who use tobacco are more likely to develop alcohol dependence and vice versa. This observation has led to these theories shared neurobiological basis and particularly involving dopaminergic reward pathways and overlapping socio-cultural factors such as peer influence, urbanization, changing social expectation. Loneliness has emerged both as a triggering point for starting the substance use and as a factor that helps to maintain the active behaviors. Coming to review of literature, there was a study conducted in 2014 by Reddy and et al., which the title of the study is The Clinical and Demographic Profile of Male Patients with Alcohol Dependence, where they found out alcohol dependence syndrome is related to comorbidities and minimize the greatest extent, and its educational and socio-economical standards are improved in the countries like India, where there is an increase in alcohol consumption as lifestyle choice. So, alcohol dependence syndrome was more common in unemployed, unskilled, and semi-skilled patients, and majority of the patients, 80% of the patients, belong to lower socioeconomic status. Another study conducted in 2017, where it tells that tobacco use is a strong predictor of later alcohol dependence. Loneliness plays a predictive role in progression from single to dual addictions. Another study conducted in 2023, it tells that loneliness is neither reducible to the individual experiences nor distinctive characteristics to the person. So the methodology, I have taken 40 alcohol dependent patients aged between 18 to 60 years who were admitted in a healthcare facility, and I have used a test audit UCLA loneliness scale, and it was a cross sectional study. Coming to results and discussion, it was seen that 57% of the population were rural and 42% of the people were urban, and coming to education, 52% have studied below 10th grade and 47% of the people have studied more than 10th standard. And coming to marital status, 57% of the people were married and 42% of the people were unmarried, and 72% of the people were employed, they were working, and 27% of the people were unemployed. And we asked a question of, are you living with a family or are you living alone? They said that they were 15% of the people were living alone and 85% of the people were living with not living with the family. And we asked another question called number of dependents, how many dependents are of you, that they said that 60% of the there were more than two, less than two people were dependent on patients, and some 40% of the people were 40% of the people had less than two dependents. And another one was history of alcohol consumption in the family. 40% of the people said yes, they had history in the family, and 60% of the people said no. And tobacco use we asked, and they said that 27% of the 40 sample, they said yes, we consume tobacco, but 72% of the people said no, they don't consume so they don't consume tobacco. Where it is interesting that when we did a comparison of audit scores across lifestyle and socioeconomic factors, where in other characteristics we didn't find any significant results, but people who don't use tobacco show significantly lower alcohol dependency. That was very interesting in this study. And we know that loneliness, the other studies tells that loneliness is very because of loneliness people drink, or because people drink they feel lonely. But in this sample of 40 people, we found that there was no significant relationship between loneliness and alcohol dependency, which was contradictory for the other studies, existing studies. And that's my presentation. Thank you.
You made a very brief presentation. Now the session is open for discussion. If anybody have any questions, you can ask. It's okay. I can ask. You have used audit, right? But do you think you can create a robust study using just one screening tool?
No, sir, it was not. It's a part of my PhD work. It is. I had just taken social details along with loneliness scale. It was just a screening tool along with demographic details. I just wanted to present. So no, I can't do a robust study based on the screening tool. No.
So at the same point of time, in the introduction part also,
Yeah.
and at the last part also, the last slide is just thank you. I was expecting some in-text citation in introduction and references at the end.
Okay, yeah. In the what PPT or the format they have sent, there was no reference.
No, even if there is format,
Oh.
but there has to be a statement. I mean, the validity of the statement should be backed by some citation at least,
yes,
right?
Yes.
And yeah, otherwise that's it. Good one.
Thanks.
You have wrote some statement about loneliness and
Yes. When I studied like previous literature shows that people who consume alcohol have have told or seen that loneliness is more in them. And when we ask qualitatively, they said that because I feel lonely, that's why I'm drinking.
Okay.
So, but in my study, in this study, we didn't find that relationship, or we didn't find that findings for us in this sample.
Okay.
That was a statement I made.
What could be the reason?
So, uh, we have done a similar study in where I did my post graduation in a Hilly. This data is from coastal Karnataka.
Okay.
So in another study where I told you about, it was from hilly region, coastal Karnataka, was Karnataka population, where people told that when we asked qualitatively, people told that it's just a recreational social gathering for we go there to drink. We need to drink. If I'm not feeling lonely, not because I'm loneliness, I'm going and drinking.
So, from my clinical experience, where social drinking is very few.
Like, and most of them are from agricultural backgrounds. My population and the another study what I was talking about, most of them were from agricultural background. And during the day, they are not able to socialize. They're not able to meet people. They're very limited to their group or limited to their farm. So when in the evenings they go, they gather, they drink, and they come back. It's just a to talk. It's a thing to party. I'm going to talk. I'm going, and along with that, I'm drinking.
What is the age criteria?
18 to 60.
18 to 60.
Yes.
It's a vast.
Yes.
Then sample also it is too low.
Yes, it's just a part of my pilot work, sir.
Okay, thank you.
Yes, thank you, sir. Yes. Yes. Yes, sir. Yes, sir. Yes, sir. Sure, sir. Thank you.
Now I would like to call our next participant, Mr. Geetesh Kumar Singh.
Yeah, I'll.
No. Also share also. So not share.
Uh, Good morning, everyone. My name is Gitesh. I'm from Rashtriya Raksha University, and today I'll be presenting our preliminary outcome of digital cognitive remediation therapy for neurocognitive deficits in schizophrenia. And it's an exploratory research, and have in collaboration with GMC Chandigarh, University of Delhi, and Punjab University. So, as we all know, that the schizophrenia has a three core cognitive components when we talk about the pathological: positive, negative, and cognitive symptoms. If we talk about the majorly cognitive symptoms, it mostly manifested as independent symptoms, not correlated definitely with the what we call psychosis, but not it's kind of independent manifestation. And when we talk about the medication that helps to treat these cognitive symptoms are not pretty much effective. And to a certain extent, the traditional remediation therapy we have, it's a limited and there is a gap of adaptation, and cost is also too high, and not that much people are trained who can cater to the need of the wild population that we are having in our country. So this pilot study basically aimed to examine the feasibility and preliminary effectiveness of this digital cognitive remediation therapy that we done using the CogBrain software that has been developed in GSM Chandigarh itself as a part of PhD program, and so in improving neurocognitive functioning in long-term inpatients with schizophrenia. So we have put forward three questions: is digital cognitive remediation therapy acceptable and feasible in long-term rehabilitation? Basically, the long-term will involve at least 3 to 6 month rehabilitation setting those patients who are if they are admitted. And the second was, are there measurable improvement in neurocognitive deficits? And the third is, does the number of neurocognitive sessions that we are providing to the patient is associated with the degree of the cognitive improvements. So to test this hypothesis, we use the pre-post intervention retrospective design, and we recruited 10 participants, 7 male, 3 female, diagnosed with schizophrenia as per DSM criteria from a tertiary care setting. And we also conducted a post-hoc power analysis, because in such cases it was difficult to have a kind of, without funding, such kind of a robust sample size. So what we started from the, we start recruitment, having baseline assessment, and then 6-month follow-up of the post and the post assessment, then analysis. So we fix the inclusion criteria. The participant should be diagnosed with the schizophrenia and age somewhere between 30 to 50, because the sample size is low, so we doesn't want to scatter it much, and admitted in long-term rehabilitation setting, that is at least for the 6 months, so that we can cover the whole 6-month period, because in very short period, 3 months, it is difficult to get the outcomes and attributed to the, this is because of the this particular intervention. And also to get them familiar with the tablet where you're delivering services, we have kept like a minimum educational criteria, that is till 8-inch standard, so that we can communicate and make them understand how these things function. Right? We have excluded those with having comorbidity, psychiatric comorbidity, or absence of any neurocognitive symptoms on enhanced neurocognitive battery, and those who are having incomplete data, or to certain extent, those, there are patient in rehabilitation setting who doesn't have caregiver, so clinical data, duration of illness was not there, so many things, so we also excluded them, or no history of substance abuse. So this is a particular interface of the software that we have utilized. It's called the cog brain, which work basically the attention, processing speed, visual memory, working memory, executive functioning, and the verbal processing speed. And best part of this application is monitor the performance on the real times and optimize the task and difficulty levels, so that people don't get like, if it's too difficult for the participant, they might not be interested. If it's too easy, they might get bored. So it adjusts it, and stimulus that we present and the text that we present are culturally relevant, like it's a local one. So unlike the other neurocognitive retraining batteries like BFT that we are having, or Cantab, those are culturally, not culturally pretty much relevant. So we followed a 45 minutes twice a week session for 6 months, and at the whole session was delivered by the clinical psychology training, and it was under the supervision of a clinical psychologist or a faculty of clinical psychology, and we also monitor the fidelity, whether the session actually are being delivered or not, through the standardized session protocol checklist. Whenever it is being delivered, there are checklists, and also using the logs that has been placed inside the application. Now, for assessment purposes, we, as I mentioned, we use the comprehensive enhanced neurocognitive battery at the baseline, and then we started delivering the sessions for the 6 months twice a week, and the post intervention we assess using the same neurocognitive battery. So we have a 2 data point, pre and post, and then we go for the analysis. So mostly the analysis that we done are the Wilcoxon Sandvik test, considering the low data that we are having, like 10 samples only, and also we go for some other non-parametric tests that we're mentioning over there. So if we talk about the demographic characteristics, all the 10 participants having mean is like 40 plus minus 6, and 70% were male, 3% were females, and average duration of illness was 11.2 years, and all were stable and on medication. So all the patients in this particular trial, not the trial, but in this particular study, were on standard treatment as usual, right? So they are all having the medication and nursing care simultaneously along with this intervention. When we talk about the percentage improvement, so we found that almost all the 10 domains that we have assessed using the enhanced neurocognitive battery, there was a significant improvement pre and post assessment, and the average improvement across the domain was somewhere like 50 to 80%. So it's a huge improvement, but we'll also discuss the limitations. Right. So this is a chart how it flows across the domains, and one interesting finding we find, like there was a one particular domain where we found like a 193% improvement, which is quite odd, and that also baffles us. But other domains for like it's a good improvement that is as expected, somewhere 30 to 80%. We also did the Friedman test along with the Wilcoxon-Sandring test to check the effectiveness and the whether really there a difference exists. And we found across the domain there was a significant difference from the pre and post timings. And the third objective, where we want to understand whether the number of sessions is also associated with the cognitive outcomes or not. And we find a significant correlation with number of sessions of mental speed and the verbal learning, these two domains that I have highlighted in the greens. So overall, if we talk about the first objective that we were having, that is whether it is feasible. So what we find is there was no dropouts, and mostly 76% of the like we have almost 48 sessions, and 76% of the session were completed by the most of the participants. So it's a good retention rate. And if we talk about the whether there is a difference or impact across the group, so earlier research are also having the similar finding. They support the neurocognitive like digital cognitive therapy do have a positive outcome across the various neurocognitive domain, like response inhibition, visual memory, verbal learning, right? And the similar finding we have to speed up. Yeah, right. So as I mentioned, that finding definitely supporting it's a feasible. There is a positive cognitive improvement, and the third one, that is there a positive correlation between the number of sessions and the outcome improvement in neurocognitive functioning. But there are limitations. The very first limitation, it's a 10, it's number size. It's a very few to generalize these findings. The design itself was a retrospective, and there was a no control group in this design. So that was a few major limitations. And if we talk about the strengths, it's a novel approach, not very novel approach, but yes, in our setting, it is definitely a novel approach. And having a strength, like we have used a robust outcome measures, and also this tool has a specific strength, but it has a real world applicability. So that is something we consider as a kind of a strength of this study. And in terms of implication, we definitely not recommend to go ahead with this. So future study can definitely build upon this particular finding. We ourselves planning in RCT on this. So once it is tested on a randomized control trial, and if given the similar result, this can be taken forward for the clinical practice. So in conclusion, this particular pilot study using Cogbrain has significant improvement in neurocognitive functionings in long-term rehabilitation patient. And the intervention is definitely feasible because it has a 100% no patient dropout and 70% of the session completion. And definitely considering the limitation that a few we had mentioned, we should recommend it not to be used in the clinical setting, but first it should go through the trials, randomized control trial, and then we may think of how the findings comes. So thank you very much, and thanks for that.
Yeah, I think it is a innovative study. So we have to appreciate the study they were doing, relevant to the conference theme also.
Thank you, sir.
Okay. So now this session is open for question and answers. Okay, so I have some doubts.
Yeah, yes, sir.
Are they, how long they are taking treatment? Is there any medication implications?
Yes, yes, sir. So one of the major limitations that we have not considered the impact, like kind of a comorbid impact of the medication that they are having or treatment as usual they are having. Right. So most of the duration of illness is 11.6 years. So most of them were on the medication and stable. Right.
So what kind of cognitive deficits you have noticed in this long-term study?
Yes, yes. So as per the pre-assessment, so we have using this basically the mental speed of processing, focus retention, and sustain. So basically the basic functions that we have assessed along with the executive functions. So it's not the specific domain, but it's scattered across the maze domains. So those who are having some basic impairment, they also have execute in other memory related impairment. So this is basically the 10 domain that we had considered for the analysis: and mental speed, focus attention, sustained and response inhibition, comprehension, verbal learning, and visual memory, learning and memory.
Okay. So are you satisfied for providing a 2 session in a week is well,
I think the outcome would be better if we go for likely at least 4 to 5 sessions per week, because there is a gap. The limitation is we didn't have the enough tablets. Neither we have enough trainees to cater those patients every day, right? So that become a challenge when we admit in the like along with their academics and all other things without funding and support. So that's definitely a limitation, and that is why we are interested in looking into the number of sessions associated with the outcome. So we definitely find a like somewhere very strong correlation with the number of sessions and the outcome. But we have only 2 data points, so it's again not generalizable, because this there could be a practice effect, there could be a time effect. Those things need to be somewhere taken care in the RCTs.
okay. Is there any significance between negative symptoms and cognitive performance?
Negative symptoms and the cognitive performance, sorry sir, we haven't measured it. Yeah, that there could be possibility because of the ongoing social skill training or the nursing intervention. These improvement could be also some to certain extent attributed to those things.
Okay, maybe in your future study, you should consider as negative symptoms.
Definitely, sir.
Okay, maybe you can make it as a comparative study. Then it will be useful to the society.
Right, sir. Thank you, sir, for your input.
Same way, like because of your review of literature, what is your understanding regarding the negative psychosis symptoms and the positive symptoms, and cognitive deficits has been seen in which kind of symptoms, negative or positive?
So mostly when we talk about the cognitive symptoms, it's a kind of independent symptom. But in negative schizophrenia, we definitely have this, and also in the positive. So what we find across the psychosis spectrum disorder, the basic cognitive function were impaired when we sustain attention and concentration.
No, I'm asking cognitive symptoms deficits are
mostly we find in the negative, sir. So acute stage and chronic schizophrenia, like for acute schizophrenic phases, if we talk about, so it's a not could be possibility to have a very severe, but in chronic it is very significant. I mean very prominent, right? And with the time passes, it get deteriorated if not taken care with a certain like holistic intervention programs.
More question. Have you heard about endophenotype? Cognitive endophenotype.
Is it like no?
Okay, maybe this is an interesting study. You try for finding cognitive endophenotype, especially from positive relatives. They have a milder form of very subtle cognitive impairments. So maybe if we can find those people, if we can do this remediation, we can prevent them for.
Sure, sir. I'll definitely look into this.
Thank you.
Thank you very
Generally, they are saying verbal fluency. Mainly the executive function deficits are prominent in those
much. The basics are intact advanced.
Okay.
And you made a very strong statement that medication has an effect on cognition. You made it, that was without any, I mean, that was with any references?
Sorry, sir.
Medication, you made a very strong statement that medication has negative side effects in cognition.
Yeah, no, I didn't say medication has a side effect on the cognition, but it definitely have. Right? I mentioned that medication hasn't proven very effective in reducing the cognitive symptoms.
Like on what basis you are telling this?
I had a reference over there where you cited. It's a meta-analysis that we have cited over here.
Okay, fine. Thank you so much.
Thank you very much.
So now we will have our third presentation. The title is Cognitive Fusion, Metacognition and Mindfulness in Individuals with Depression Disorder. Miss Apurva, yeah, please come. And also, I would like to request participants before beginning the presentation, so please give a brief background about yourself so that we also get to know. Okay, and the time is 8 minutes. Good morning, everyone. My name is Apurva Vadura. I had done my BA Honours Psychology from Andhra University, MA Psychology from Punjab University, and MPhil in Clinical Psychology from MIT University, Punjab. The topic of my presentation is cognitive fusion, metacognition, and mindfulness in individuals with depression disorder. So, depression remains one of the most debilitating mental health condition. It affect our day-to-day functioning. So, it is characterized by maladaptive cognitive processes like rumination, cognitive fusion, and dysfunctional metacognitive beliefs. So, cognitive fusion is over-identification with one's own thoughts. Metacognition is awareness and regulation of one's own thought processes, and mindfulness is non-judgment present moment awareness. So, conventional treatments like antidepressants or CBT show moderate effectiveness, but patients still experience residual symptoms. So, the studies shown in the table have studied these constructs that are metacognition, mindfulness, and cognitive fusion independently, but none of these studies have studied these constructs together. So, our research problem was that there remains a significant gap in understanding how these constructs interact and jointly influence depression. The theory of metacognition does not clarify the specific role of mindful attention awareness in depression, leading to conflicting findings in the literature. By focusing on these interconnected factors, we can bridge this gap and explore how these psychological constructs influence depression together. So the aim of my study was to explore the interplay between these constructs in patients with depression disorder, and my objective was to assess and compare the level of these constructs in mild, moderate, and severe depressive episodes. So, 50 participants were recruited by using a cross-sectional design via purposive sampling. It was conducted at the Department of Psychiatry at Dr. B.R. Ambedkar Institute of Medical Science, Mohali. So the inclusion criteria were individual meeting ICD-11 diagnostic criteria for depressive episode. They must be between 18 to 65 years of age, and they must have the ability to read, write, and comprehend. The exclusion criteria were comorbid psychiatric illness, cognitive impairment, organic conditions, or substance abuse. These are my data collection tools. primary data collection tools. These are depression inventory, period 21 for measuring depression, the metacognition questionnaire 30 for measuring dysfunctional metacognitive thoughts, cognitive fusion questionnaire 0 to 7 for measuring cognitive fusion, and mindfulness attention awareness scale to measure the level of awareness in people about mindfulness. So my procedure started after getting the approval of Institutional Ethical Committee of AIIMS Mohali. Participants then received comprehensive information about our study purpose, and after it, written informed consent were taken from participants. Socio-demographic data like age, gender were collected through socio-demographic sheet. Clinical details like age of onset of depression, duration of illness, duration of treatment were collected through clinical data sheet. We also did preliminary screening through general health questionnaire 12 to assess psychological distress. After it, we did our comprehensive assessments that were described earlier. And statistical analysis was done by Exposis version 24. And one way and another were used to test group differences in different constructs and Pearson's coefficient correlation and linear regression analysis assessed the relationship between constructs. So this table represents the participant characteristics across different variables like age, sex, or the participants who were whether they had mild depression, moderate depression, severe depression, and their education. And this table represents the median score which we got from each questionnaire and their respective ranges. So, like in GHQ, we got a median score of 7. And this table represents the correlation between different constructs through Spearman's correlation coefficient. As we can see, if I say there is a strong positive correlation between cognitive fusion and behavioral to depression, that is 0.808. Which is the strongest, and the second strong was between dysfunctional metacognitive beliefs and depression, that is 0.753. This is a scatter plot which is showing the relationship between dysfunctional metacognitive thoughts and depression. This scatter plot tells that as the level of depression increases, the person has more dysfunctional metacognitive beliefs. And what this table, this scatter plot shows that it shows the negative relationship between depression and mindfulness. As the person is more depressed, he is less mindful, and vice versa. If he is more mindful, he will be less depressed. And this scatter plot shows the relationship between metacognition and fusion, more into functional metacognitive beliefs, and the more into cognitive fusion. So, coming to discussion, our studies were comparable to all these studies. But the limitations of our study was that we used a small sample size that was 50. So, subgroup analysis on the basis of different variables like whether age or gender was restricted, which inflates the sampling error. We did purposive single site sampling, which restricts generalizability. We used a self-report questionnaire. We don't use clinician-rated questionnaire. So it increases social desirability. So the takeaway main message is that the role of psychological inflexibility exists in the phenomenology of depression. There is negative relationship of mindfulness with distress and depression implies that mindful awareness reduces rumination and depressive symptoms. Our findings support targeting cognitive fusion and dysfunctional metacognitive beliefs. And while fostering mindfulness to mitigate depression, at one area we have to target cognitive fusion and dysfunctional metacognitive beliefs. In another area, we have to foster the mindfulness, the level of mindfulness of the patient. And this is also consistent with acceptance and commitment therapy, ACT, focus on cognitive fusion, metacognitive therapy, and mindfulness-based cognitive therapy. So the future research directions are that there are need for more randomized controlled trials comparing ACT, MCT, and MBCT, and more longitudinal cohorts are necessary to clarify the cause and effect and temporal precedence over a period of 12 to 18 months. Thank you. Yes. Text.
Patient or you rated a depression? Have you taken the patient's diagnosed with depression or what is your sample?
The patient diagnosed with sample according to diagnosed by psychiatrist at that hospital in Somali.
What is the criteria?
So the patient that he must meet that.
With depression even was rated by you or
Uh, Sir, it was it was self-report patient rated. Yes.
what is the education of the patient?
Sir, it was different. It is shown in the base participants. They were different, like 6% from 10 standard. Most were postgraduates, that is 42%. 32% graduation have done graduation, and 20% 12th standard.
They 10th of standard able to answer the question.
Sir, whenever they had any doubt, I translated that depression has it. I mean, it is also available in Hindi. So, and whenever they had any doubt, I answered it. I was, and who were comfortable in English, they did in English. Who were comfortable in Hindi, they did in Hindi. And
You suggest the PDI can go for Hamilton or HCS, hospital and safety depression.
yes, sir.
That would be better instead of going for that.
Yes, sir. Hamdi or they are better. They're clinician rated, so they are better and they have more reliability. Just, just for there was a time constraint for us, so we can give two participants at the same time. So I thought I would be able. It would be difficult for me to assess both. Was it is clinician rated, so I thought it is better if they fill out by themselves.
One more thing here,
Yes.
like the age range was age range.
Age range, yes, sir. Age range.
I think it was age till age 65, right?
Yes, sir. Yes.
And you took cognitive symptoms. So don't you think,
Yes, sir.
I mean, by the person is age 60, 65, there will be definite cognitive symptoms.
Yes. That age-related cognitive symptoms. Okay. Uh, so there will be cognitive symptoms, but the symptoms which occur in depression while a person is depressed, especially severe depression or moderate depression, it is I think these days are that are different, like memory based, which is due to depression. But yeah, they can uh, they can clash. It might
There will be certainty, they will be clashing.
clash.
There are cognitive deficiencies.
Yes.
Now, secondly, like, how did you elicit the cognitive symptoms? Like, you have written about the exclusion criteria, cognitive impairment.
Hmm.
So, organic condition. Can I just know how did you elicit these things?
That the psychiatrist who with whom I was doing my co-author, Dr. Ikram Goyal sir, he matlab, so said so all the he has exclusion criteria. He should not have any comorbid psychiatric illness. It was assessed and interpreted by the psychiatrist properly about the exclusion criteria. How? Hmm. So, through his clinical experience and in MSc also, we of it has the through.
Eligibility for a research purpose. Whether you certain focus too,
Okay.
then you can give the cognitive impairment criteria.
Okay.
Maybe you can MMSC or
MMSC, yeah. Yeah, it is. It will not take much time. Mocha is certain Mocha and MMSC. Yeah.
purpose here.
GHQs are just there was a curiosity that GHQ is used as secondary assessment tool. So there was also high correlation between the scores of GHQ and PDI and other. Purpose was to see the general distress because the purpose was that in future, if it is not possible to do all the assessments, so if a person has high GHQ scores in one, मतलब अगर किसी के GHQ में ज्यादा होगा तो तभी हम आगे बढ़ेंगे इसके लिए. Okay, so GHQ 12. Sir, reference of GHQ. एक बार can you come here चला.
You have used
Yeah, I can which one do you want? Reference or
No. There are different versions of GHQ. No, GHQ 12, 24. Which version you have used? 12. What is the cutoff? Yeah.
Sir, actually, that 12 there are 12 questions and 4 options. So I think the cutoff is that one for around 12 to 144. But I don't remember the numbers exactly. Thanks. Our next paper presentation title, Understanding Adolescent Deviance in the Indian Context, Pilot Findings from a Scale Development Study. Mr. Ayush, come.
You can put up whatever PDF or presentation, either one of those. Good morning, everyone. My name is Ayush Bukhare. I am a forensic psychologist as per my qualifications. Currently, I'm a PhD scholar at Rashtriya Raksha University. My PhD is being done under Dr. Jasbir Kaur Thadani. So, for my PhD topic, I am trying to standardize a scale. I'm trying to develop and standardize a scale, which is basically to be used on school-going adolescents to screen or as a preventive tool for them to not get into any kind of deviant behavior. So this current study, I'm going to present my pilot study. It is titled Understanding Adolescent Deviance in the Indian Context, Pilot Findings from a Scale Development Study. So, as per global level, India currently has around 253 million children, which who fall under the age range of 10 to 19 years. For this particular study, I've only taken adolescents who fall under the age of 13 to 18. As per NCRB, it states that majority of crimes that were committed were by adolescents who come under the age range of 16 to 18. Now, adolescence, as we all know, is a phase of life where there are multiple changes that one goes through, be it biological or psychological or even social, because we all expand our, let's say, our social circles, let's say, our experiences in life, as well as there are biological changes that take place. Now, next, my literature is also about the fact that there are a lot of psychological tools that are being used for adolescents and for this particular purpose, but also the fact that most of the psychological tools that are available that are currently being used in India are either they are only majorly diagnosing certain kind of mental disorders, or they are not developed in India. They are not culturally tailored for Indian population, right? So there's a particular study which did definitely conclude that there is a lack of integrated analysis across domains for the identification of delinquency proneness in adolescents. With this particular skill development, I do not aim to look for any mental disorders or any mental issues. We, of course, there are a lot of aspects that we all experience, and we all, you know, uh, may be processing it in different ways. And of course, they do affect all of us mentally as well. But at the same time, I am not looking out for any mental disorders. I'm looking out at, for the grassroots level from where the problem is actually stemming from, which is basically the psychosocial factors or the biological factors, right? Um, yeah, so as per again my review of literature, risk assessment, according to Chaudhary et al., they found out in 2016 that a risk assessment may aid in determining the type of intervention that will best suit the juvenile's needs and decrease his or her risk of offending. Because if any individual possesses certain risk factors, this particular research indicates it will increase their chances of becoming a delinquent. So there were a lot of characteristics like empathy, resilient behavior, and social adjustment, which proved to be crucial during intervention, and particularly in the varied and interconnected cultural diversity that we all experience in a country like India. Now, while I was going through the process of developing an item pool for this particular scale, there's a particular theory that I came across, which is about, which is called the Bronfenbrenner's ecological systems theory. Uh, as per the diagram that you can see, there's a child who, first of all, experiences the microsystem, which is their immediate connections. Microsystem consists of your friends, of your family, your classmates, maybe. Those are your immediate connections. After that, these microsystems they interact with each other and form a mesosystem, where your friends and now your family they are all acting together, and that is how the behavior or the emotions are shaped of a child. After this, we come on to the broader system, which is the exosystem. Exosystem is can be consisting of any kind of conventional or unconventional authorities over you. Let's say the school authorities or the family friends, people who are connected to you, but not as directly as your family directly, or like your friends. So these are your exosystem. These are the people who you interact with in the exosystem. Next broader system that we have is the macro system. Macro system consists of your social and cultural values that are generally expected out of you in a society, the social cultural norms that we all need to follow generally, and then there is the chrono system, which is your entire belief system that we talk about. Now, this particular theory was expanded by the biopsychosocial model, where basically it is believed that every child is shaped by their biological and social as well as psychological facets. Uh, Now, at the heart of both of these theories, there's also social control theory, which basically tells us that we all exert a certain kind of control because of which we. Okay, all right. Thank you, sir. So, so this particular study was a quantitative correlational study, and we have particularly attempted purposive sampling method because it was a study where we had to include only the school-going adolescents. Now, I've done data collection on 500 school-going adolescents who belong to government as well as private schools, and those schools were also belonging in urban, semi-urban, and rural areas. All right, sir, I would like to just briefly, I would like to say that all the theories that I had previously mentioned, from that we had come down to 6 factors, which were attitude towards the school, social behavior, emotional health, interpersonal behavior, empathy, and experience as a student. These were the 6 factors based on which the entire scale was formed. So the inclusion criteria was that the individuals will fall under 13 to 18 years of age. They will belong to all sort of socio-economic strata, belonging to urban, semi-urban, and rural areas. And all the genders were included as well. Any child who had a previous mental history or the family had any kind of previous mental history were excluded. There were 95 items in the initial item pool that were formed based on the 6 factors that I previously defined. Now, after the data collection, the data analysis was done on SPSS, the version 31, which was released in June. So the entire scale had the Cronbach's alpha of 0.839 as an entire scale. And while if we did the internal consistency analysis, subscale A, which is attitude towards school, was 0.719. Subscale B, which was social behavior, had Cronbach's alpha of 0.696. Subscale C had 0.671, which was emotional health. Subscale D was interpersonal behavior, which had Cronbach alpha of 0.626. Subscale E was empathy, 0.924, and subscale F, which was experience as a student, was 0.618. The future steps are going to be exploratory factor analysis, which will help me reduce the number of items from 95 to something around 30 to 40, which will basically be less time consuming considering it is a screening scale. We will also be refining the content for better comprehension and clarity, and further data collection will also be conducted for standardizing the items and also to develop the norms for the scale. The Cronbach's alpha 0.839 as a reliability coefficient for the entire scale looks like a great number, and also the ranging of 0.618 to 0.924 for all the subscales also look great, and I think after the EFA the reliability coefficient can also be improved. Also, empathy stood out with a high reliability of 0.924, which basically uh, is is a testament that empathy can be considered to be a driving factor for pro-social behavior. So, yeah, the limitations. The pilot study had a few limitations, which is subsequent research. Considering it's a big country and there's a lot of area to cover, and because this scale was specifically being made to fit the Indian culture, so it was definitely difficult to reach out to each and every area. There are certain remote areas that we could not reach. However, in the number of 500 people that we have covered, we tried to cover each and every 5 zones, including east, west, north, south, and the central India. So we have tried to have like urban and rural as well as semi-urban areas. There are certain areas that we could not reach, so that could be one of the issues. So we can generalize it, but not for each and every uh, geographical area. So that was my study. Thank you, sir. From the floor.
Hello, Ayush.
Hello.
So, what language have you like in what language this scale are you developing in?
So the scale is in English.
In English.
In English.
And you have covered across the like 4 regions of the country.
Yes.
Why you choose English language, not any regional language?
I could actually go for Hindi as it is a national language, but also Hindi is not a language which is very much popular in, let's say, eastern states of India or the southern states of India. But English is a language which is majorly being used across India, so that is why we look for it. But also, I've made sure that the items that we've constructed, they're in very basic and layman terms, so any child who has even learned English for 5 years can definitely understand that.
And your population is 13 to 18. Do you think are there any potential limitations could be because of this selecting English language?
So, because I'm looking for deviance, there can be a lot of newer ways of how deviant behavior is displayed. So, definitely, my scale will be wanting to. It has to be renewed maybe every 10 years or stuff, because there are newer trends coming up with the cyberspace and cyber crimes also coming up. I think we have tried to include those aspects as well. But again, as new trends come up, we will have to update the scale accordingly.
Thank you.
Thank you, sir.
Firstly, I would like to congratulate you for a really good presentation.
Thank you so much.
My question is, what's the age range for
the age range for the scale is 13 to 18 years of age. Yeah. Yes. Yes. We have certain negative answering questions basically, which we majorly had so that we reduce down the any kind of social desirability that might come up while they are answering the questions. So we have tried to incorporate those questions as well. They will come up. Yes. Thank you.
Okay. See, this is a very interesting and good area. So right now, juvenile delinquents are increasing. From my personal experience, every day I am certifying 2 juvenile delinquents in my department. Okay, so far I have reached close to 10,000 juvenile delinquent assessments. Okay, so we used to admit them in a ward. We have in Tamil Nadu, there is a behavioral medicine ward. So we used to admit for a week time. So we'll do all the psychometric assessment, and finally we'll submit our report to the JJP board. Okay. Sure. So you have given some subdomains.
Yes.
Okay, in that contact details, contact behavioral issues is included.
Oh,
like substance abuse or anything related.
Yes, sir, we have included.
But in which category it is?
Sir, actually, the thing is, we directly did not. I mean, I'll just come up with that slide. So, substance abuse and questions like that are included in the social behavior, because that is something that we can get involved with a friend, or there can be influence of a friend because of why I'm getting into substance abuse. So, we have included those questions in those.
Something related to social media?
Yes, sir, social media.
So nowadays, what is that? Instagram.
Yes.
So all the JJP, especially cases from the POXO.
Yes.
So POXO, everybody have an Instagram related account they have used.
Yes. So I have included social media. In fact, cyber-related few questions regarding their behavior towards other profiles and how they are experiencing social media in general is also included in the social behavior domain.
So okay, this is what is a basic understanding why they are getting into the deviant behaviors?
Sir, it's
depending
not
on your samples you have discussed.
So there's not just one factor that is playing role here. We majorly have it's either the family's history who have certain, either let's say there is a elder cousin who is like a gunda, so this child is also learning to be like that. Then there is neighborhood which also plays role, and majorly the biggest social circle that a child experiences is their school, because that's where they spend most of the time outside their house, which is at around 8 to 9 hours or 10 hours in the day. So school and experiences at school with the classmates, and also from the teachers, how, what kind of experience are they getting from them, how are they being treated by those authorities. So these are the major factors which have shaped like a sort of their behavior and their experiences.
In our area, mostly the school dropouts, individuals with learning difficulties.
Yes, sir.
So they are more prone to get into this type of delinquent behaviors.
Yes.
Then most of them have a early exposure to alcohol or cannabis.
Yes.
So initially it starts from the 7th or 8th standard. They used to bunk the school, go for some common places. They mingle with elders.
Yes.
And for elderly people, they'll assist them for getting some snacks or tea, whatever it is. Slowly they will learn all those behaviors.
Yes.
People are getting training. I don't know. And Madurai is very famous. Okay, for entering into the severe criminal issues. So they will take a training.
Right. But I don't have it on the pen drive with me. I can just read it out. So the questions are very basic, like I don't feel like going to school. Yeah, they're as basic as that. I'll just come up with it.
Because you mentioned a 5-year-old child can understand that question.
Yes, yes. Yes, so the questions are, I feel scared to go to school. I often feel left out or lonely. Um, I say sorry when I hurt someone. This is like for empathy. Yeah, so these are the kind of questions. I sometimes break rules. Yeah. Thank you so much. Thank you, sir.
Thank you. Thank you for the presentation.
Okay, so the last presentation of today's session, the topic is understanding parental mental health and support needs in caring for children with autism, a qualitative study. Miss Madhurima, please come. Thank you for time. Yes. Good morning, respected chairpersons, senior professors, and my dear colleagues. I am Madhurima Neglu, MPhil from Ranchi Institute of Neuropsychiatry and Allied Sciences, RIMPAS, under the guidance of Dr. Mashrur Jahan and Professor Dr. Amul Ranjan Singh. I'm here to present a research study titled Understanding Parental Mental Health and Support Needs in Caring for Children with Autism, a qualitative study. Autism is a neurodevelopmental condition affecting children's interactions with others, their communication, learning, and behavior. Thus, it adversely affects the children, but it also affects parents. In a familial setting, parents have to process shifts in roles and responsibilities
manage financial liabilities, and carry out caregiving activities simultaneously. Thus, parental distress is multifaceted and pervasive, and it often begins long before a formal diagnosis is provided. Issues like lack of awareness, uncertainty about the condition, and limited access to instrumental and informational resources adversely affect parental mental health outcomes, then impacting their caregiving ability. Hence, it's important to understand parental mental health needs and their access to resources to provide the right support and reduce adverse outcomes for both parents and children. Previous literature has also shown that parents of children with autism often have a range of informational, psychological, and social support expectancies when it comes to caring for their children. Unfortunately, however, parents in India have limited knowledge of autism and the care pathways involved, and they may not be aware of their own support needs. Also, caring for a child with autism has a serious impact on parental stress and quality of life. And research has also shown that parent satisfaction with support services is also associated with their psychological well being. There is a dearth in research studies focusing on parental awareness of support avenues and their needs in the Indian context. There is limited research incorporating both parental support needs and their mental health needs. Also, a need for in depth understanding of parental mental health outcomes is highlighted. To this end, the present study aimed to understand parental mental health needs, their informational and instrumental needs in the context of caregiving, and to gain an in-depth understanding using a qualitative approach. Coming to the methodology of the research, a purposive sampling was used comprising of 5 parents of children with autism aged between 24 and 54 years. The sample comprised of 4 mothers and 1 father, and all the participants were residing in urban and semi-urban areas in Jharkhand. The procedure of the study included approaching the participants, obtaining their informed consent, and building rapport. Then, in-depth semi-structured interviews in Hindi and English were conducted using interview guides prepared for the research study. The interview guide focused on parental awareness and knowledge of the autism diagnosis, their perceived availability of support, and the mental health impact. The obtained data was then analyzed using thematic analysis as given by Brown and Clark, where the data was transcribed verbatim, then different codes were extracted, and then themes were finally named. Ethical considerations like informed consent regarding the data collection, audio recording of the interviews, and data analysis was obtained. And finally, the participants were debriefed about the studies once the results were obtained. Looking at the results of the study, this is the thematic map highlighting the 4 broad themes, which are identifying the signs of autism, awareness of governmental provisions, mental health needs, and availability of resources, which also have the subsequent sub-themes. Let's look at the results a bit closely. In the theme of identifying the signs of autism, there was a late cognizance of developmental delay on the part of parents. There was a lack of awareness of autism, and parents compared the development of the child against age appropriate skills. Awareness of governmental provisions included a lack of knowledge about the disability certification process and about the concessions and benefits of the disability certification. When it came to availability of resources, there was a perceived lack of professional guidance, financial resources, family support, and an inadequacy of occupational and speech therapy resources. Mental health needs included dealing with the initial denial of the diagnosis, stress and worry about the child, and lack of time for oneself. Discussing these findings further, parents had a delayed understanding of the child's developmental delay, which related to their lack of awareness of neurodivergent conditions like autism. Parents often understood their developmental delay by comparing the child's milestones with those of older siblings or cousins of similar age. Parents were unaware about the UDID process, which is the unique disability identification card process, and hence they did not apply for the certificate despite having the clear diagnosis. There were issues regarding uncertainty about whom to approach, what are the steps involved in getting the certificate, and it led to significant academic losses for the child and financial losses for the parents. Lack of accessibility of information also related to delayed treatment. There was an inaccess to adequate professional help, which was either because the help was geographically remote, financially unaffordable or insufficient in quality. Parents coming from middle income backgrounds and with financial constraints often sought government sponsored treatment programs which were delayed in terms of their deliverance. Mothers particularly experienced a lack of support from their families, especially spouses, which added to their caregiving burden. There was also limited availability of therapists with very few home-based OT services for children with severe behavioral problems. Therefore, children with problem behaviors who could not be placed with other children did not get access to these OT services. When it came to mental health needs, there was a sense of denial due to inadequate awareness of autism. Denial also served as a protective response, which led parents to seek multiple medical opinions, which delayed the treatment. Despite recognizing the child's atypical development, parents struggled to accept autism's irreversibility and hoped for a cure. Hence, they stressed over the child's health and worried about the child's future. Lack of social support often left parents feeling overwhelmed with no time for self care. Coming to the limitations of the study has limited generalizability across other parent demographics and there's limited scope for fathers' perspective on their support and mental health needs. Hence, future research can improve the generalizability of findings by using a more representative sample across different parent demographics. It's also important to study the impact of support availability on parental mental health outcome and caregiving. And the need of the hour is also to understand the support needs of professionals who work with children with autism. The implications of this research study are multifold. It highlights the importance of providing psychoeducation to parents about autism, which will help in early identification and diagnosis. There is a need for developing intervention to manage the adverse effects on parental mental health. There's also need to mobilize social support systems for better parent management. Community-based research networks can be collaborated, making informational, mental, and instrumental support more accessible to parents. And and finally, policy level changes need to happen to make information on disability certification and benefits more accessible to parents through mediums of schools and hospitals. These are our references, and thank you for this opportunity.
Hello, Madhurima. So, it's really good to see that some working in the domain of mental health support for the caregiver of autism. Could you define the differences between the two variables you have taken in your literature review? One is the resources available, mental health need are available, but what are the specific mental health of this caregiver that you are trying to assess?
Mental health
need, yeah.
Yeah. The first mental health need is psychoeducational support when it comes to dealing with the initial denial. The second mental health need is psychological interventions when it comes to working with stress and worry about the child. And the third would be availability of social support to deal with lack of time for oneself and a sense of overwhelm.
And how do you understand it's a mental health need?
Based on the interviews that I had conducted, parents often reported that this is something that lacked. They did not explicitly say that this is something I need, but based on the words, ये हमें नहीं मिलता है, कोई हमारी बात नहीं सुनता है, that is how I derived the theme in that manner.
Let's say if a parent say कि हमारे पास गाड़ी नहीं बच्चे को यहाँ पे लाने के लिए, will that be a mental health need?
That would be an instrumental support need.
Right. So better. One question that is basically exploratory in nature and very beautifully you have described. The theme emerged in the mental health need is a sense of yeah, that's right.
Oh.
Yeah. The one need the sense of something. Yeah, a sense of denial due to inadequate awareness of autism. How you derive this sub-theme?
During the interviews, parents often said that, the question was, how did you get to know about the diagnosis of your child? How did you get to know about that they have autism? So a lot of parents said that initially when we saw that the child was not talking to other people, not maintaining eye contact, because we did not know that something like autism exists, we just denied it. We just said that लड़के late बात करते हैं, लड़कियां shy होती है. So we tried to push it under the rug as much as we could until the time they could not get admissions to school and we had to deal with the issue. So there was a denial in accepting that, okay, this is not normal for my child. But because I don't know what else could be the possibility, I just ignored it for the time being.
You have explained it beautifully, but what I think when it's an exploratory research, we don't like put it forward as a cause and effect relationship, right? Because there could be so many variables to be explored, right? So it's better if we put in some different terms, sense of denial, not due to inadequate awareness, but yeah, sense of denial could be one of the themes.
Absolutely noted. Thank you so much for the feedback.
Right now, nowadays a lot of very less qualitative studies are done. Mainly the quantitative studies are done. What way to take this? Because it's more biased, more exhaustive, it is tiring, and even the reliability, validity of the qualitative study is there. What way to take this?
Sir, the first most logistical concern was, would I get enough sample size to complete a quantitative study? And second was because I wanted to understand what needs parents had and there were not enough scales for me to help measure those. I thought, let me just get into it qualitatively and see what comes up, and then maybe I can, work on generalizing the findings a bit more.
In my opinion, they are getting a number of marks. Okay. So right now, all the other development disabilities are reduced. I used to see every day minimum 2 cases. That many number of some are diagnosed. I don't know if it is overdiagnosed, but cases are coming very frequently.
Yes. So perhaps yes. Yes.
Definitely, all the parents seeing many families separations are happening. Fathers are taking care of the children. Then there are families 2 children with autism. So, like last week also, I met a parent. They are based in Bangalore. They don't know what to do for taking therapy. One therapy for one center, another therapy for another center. Their daily routine, everything is spoiled. They are behaving like a robot or machine. Nobody for them to understand their emotions, feeling. They go for one center, they'll see. You go this center, they are giving good treatment. I heard that in Bangalore, getting appointment is very important. So, providing therapy for these people.
So one of the participants in my study had even been to CMCH Vellore for treatment, and then they came back to Ranchi saying that now we don't know what to do.
No, that is the usual people from the western part of India. They used to travel.
Yes, yes.
Then none of the parents are not convinced about the rights. They keep on shopping here and there. The service providers also very limited. Mostly the part practitioners are earning more money and doing unqualified.
That's very unfortunate.
So that we need to educate.
Yeah, absolutely.
Being a professional of their rules of speech therapists, rules, psychologists. So those kind of education also. It's a study.
Thank you so much.
Thank you all the participants. Thank you, Chairperson. Best paper award will be declared tomorrow. Okay. Any further questions? Anything? Okay. A certificate also you will receive tomorrow. Thank you. Good afternoon, everyone. So we are going to start with the symposium, which is titled as Revisiting Self-Compassion from Concept to Practice. So before we start the symposium, I would like to introduce you to our chairpersons. First chairperson, Dr. Victoria Talwar. She is her affiliation and designation is in she's in Canada Research Chair Tier 1, Director of the Gold Center for Early Childhood Development, McGill University. Yes. Her her areas of interest lies in children's adaptive and maladaptive development, the development of children's lie telling, promotion of children's honesty, and interview practices for their accurate, honest reports. Dr. Victoria Talwar has a long list of awards and recognition that includes King Charles III Coronation Medal, Fellow of Royal Society of Canada, Association for Psychological Science, and the American Psychological Association, Society for Research in Child Development, Early Career Research Contributions to Child Development Award, and the list goes on. I would kindly request Dr. Kirti Pai ma'am to please come and felicitate Dr. Victoria Talwar. Thank you, ma'am. Our next chairperson is Dr. Sudipta Roy, who is the Director of Silence Center, Surat, Adjunct Professor, PPSU Zonal Vice President West, CPSI, and Vice President Psychodermatology Association of India, President in MMHF, General Secretary West in IAHP, and Editorial Committee of IJCP and IOPS. Ma'am has over 31 years of experience, and her areas of interest lies in child and adolescent mental health, neurodivergence, psychodiagnostic assessments, and psychodermatology. She is also the 3 times recipient of Best Paper Award in national conferences, twice recipient of the National Merit Scholarship. I would kindly request Ms. Smriti Joshi ma'am to please come and felicitate Dr. Sudipta Roy. So we will invite the speakers now for the symposium. The first speaker for the symposium is Dr. Uday Kumar Sinha, who is additional professor and former head, Department of Clinical Psychology, Bhas, Delhi, who has more than 31 years of experience of teaching, training, and research. I would kindly request Dr. Victoria Talwar ma'am to please felicitate sir before we start the symposium. The next speaker of the symposium is Dr. Prerna Sharma, who is Associate Professor of Clinical Psychology at IBHAS, New Delhi, who holds a PhD in Clinical Psychology from Punjab University and MPhil in Clinical Psychology from GMCH, Chandigarh. I kindly request Victoria Talwar ma'am to please felicitate Dr. Prerna Sharma. And our last speaker for the symposium is Ms. Jasleen Kaur Sajdev. She is an MPhil Clinical Psychology trainee at IBHAS, and she's All India Rank 1 in MPhil Clinical Psychology entrance exam, and also UGC NET qualified. Welcome to Jasleen. And I kindly request Dr. Sudipta Roy ma'am to please felicitate Jasleen before we start the symposium. Welcome. Thank you. So we now begin with the symposium. Over to you.
Good afternoon. This symposium is a unique experience to me in 2-3 ways. The first is shared by my colleague. We had done together in our training in demands. So Dipta was and me was the contemporary there. So this is a good exposure. Lot of my students, they are sitting in the audience. So this is another important observation here. Anyway, let's begin. When we planned this symposium on self compassion and try to revisit it and make some sense out of it, we planned with, in fact, 6 speakers, and finally we are doing with 3. So the 50-50 rule has been proven correct here, from planning to implementation. So Now, the purpose of keeping this particular symposium is to raise certain valid issues. I mean, definitely not to, do it only for academic reason, but basically to stimulate young researchers or young therapists uh, to just consider a few things in their mind, and then when they start doing anything related to self compassion. Now, self compassion as a term, I mean, I think it's not unfamiliar. We all know that this comes from the Buddhist philosophy, and it's a kind of attitude towards oneself, which is necessarily meaning that one should care and be kind to oneself in order to avoid many unpleasant emotional experiences and feel good about. And then the necessary component of self compassion is self kindness, sense of common humanity. Means the attribute and the attitude is not something which only one individual should keep. I think it is common to all, and it gets benefit to entire humankind, and that is the meaning of a sense of common humanity. Mindfulness is a that is also very known concept, which is being aware of things and experiences without being judgmental or no drawing any conclusion out of that. So these are essential component of self compassion, and self compassion has been proven having a very strong ingredient in it, which has therapeutic value. And if we look at the progression of therapeutic approaches, particularly new generation therapy approaches like mindfulness based cognitive therapy or dialectical therapies, and later on, so right from Kabat-Zinn to Lenan to Gilbert, who has talked about compassion focused therapy. I think some element of self compassion has always been there. Now, self compassion as a concept is not limited to being a component of therapeutic approach. In fact, it has the potential of become an independent therapeutic approach, and people are trying to use this as independent therapy. Now, this requires some amount of preparation, some amount of carefulness. There are a lot of challenges to it, and before daring into the practice of self-compassion as therapy, I think one has to be ready to do that. It's not only the attraction or the temptation to go into the self-compassion as uh, therapy method. I think the main aim is to bring that particular component for discussion, and with that we have planned this symposium. um, Dr. Prerna would be talking about the concept and the background. Jaslene will be focusing on the reflection when somebody does practice self compassion as intervention method. What are the experiences and what are the learning? I think her presentation is centered on that. In fact, I would like to give credit for this symposium to Jaslene, because it is her curiosity, desire, and enthusiasm to do something. Because if I am doing something, let me share it with somebody. So she has been very instrumental behind the planning. I will not take time here. I will ask Dr. Prerna to make her presentation.
Ma'am, which one from this? The first one. All right, at the outset, I want to thank the chairpersons and the audience. I would also request people at the back if they can come forward, and it's a didactic sort of lecture, and I want to interact um, with the participant and not just deliver, because it is self compassion. So a lot of focus on oneself. I'll be touching on concept and application of compassion focused therapy and how do we translate it into contemporary practice across mental health interventions and other mental health interventions that is available to us. Before I open up what CFT is, it's just a food for thought for all of us. I want to ask the audience that if they are to describe what kind of world we live in, what is the world? What is one word that comes to the mind? What kind of world we live in? How do you describe living in this world? What kind of world do we live in? Chaotic. Okay. Fast, harsh, rushing, chaotic, self-centered, judgmental, unjust.
Yeah, Dr. Prerna,
Challenge.
I just want to remind everyone about the time limitations that we have. This is not to stop you from this exercise, but just to inform you that the entire session is of 45 minutes.
Yes.
Thank you so much. Thank you. Yes.
So none of this is a positive connotation to the world we live in. So now, when I was thinking about this yesterday, I put out something that came to my mind: hard driving, perfectionist culture, high burnout, lot of self-criticism, fear of failure, social comparison, and competitive world. These were the things that came to my mind, and all of that you have added to this. If this is the reality, then how do we bring in a concept like self-compassion to this reality? And coming back to our context, because self-compassion can look cool, can look feasible for a monk sitting in Himalayas, but self-compassion can be equally challenging for us in this kind of world that we are talking about. Hence, although self-compassion is not something which is contemporary, it has always been present in Eastern philosophy. But given the Indian context, although it is coming from Eastern philosophy, but the context of India is contradictory to it. How? India as a collectivist society is shame-oriented and critical. How many of you agree with this? People with high level of shame and self-criticism can have enormous difficulty in being kind to themselves, feeling self-warmth, or being self-compassionate. So it is an inherent contradiction of our society and culture. Shame and self-criticism are rooted in histories of abuse, bullying, high expressed emotions, neglect, and lack of affection. This is all the research that talks about it and way back. Hence, individuals can become highly sensitive to threats of rejection or criticism from outside and quickly become self-attacking. So this is the narrative that we grow up with. This is the narrative an adolescent or a child is taking from the environment or from the parents, that I'm supposed to be doing this. Or, when we, in clinics, when we are interacting with adolescent or young adults or even adults, when we trace back their childhood history and early childhood environment, we realize that it is somewhat shame oriented, it is critical, and that's why the perfectionist tendency. So they are all correlated concepts. Because of that, the clinical focus of CFT is even more becomes even more pertinent. What if you tell the client that the most powerful antidote to mental distress isn't striving harder, which they get that's the self story that they have, but softening the internal response to suffering. What if we approach suffering without fighting, without participating in it, like the third wave therapies that we talk about? What if we soften around suffering? What if we don't try hard to elevate the suffering in the sense that we want to cut down the suffering? What if what is suffering is the reality? What do? We change our response to that suffering. That is CFT. Now introducing the concept. Of course, it is a third wave psychotherapeutic approach, and Sir has mentioned Paul Gilbert, that it has from John Kabat-Zinn to Paul Gilbert. And in 1999, he came up with a formal therapeutic approach. It is an integrative therapy that draws from evolutionary, social, and developmental perspective, Buddhist ideas, as well as neuroscience. I'll touch upon the neuroscience part of it briefly. It is developed to treat shame, self-loathing, and self-criticism. If we find people in our clinic with high shame and high self-criticism or high perfectionist tendencies, I think that's a good point to start or introduce self-compassion. It is diagnostic. It is not related to a particular diagnosis, and it is used for diverse condition. I briefly touched upon that what happens in our early childhood environment. So some indicators that self-compassion may be needed or we need to cultivate it, because empathy can be neuroscientifically, empathy can be wired, but self-compassion is cultivated. So self-compassion becomes a skill, although empathy is something which develops as a part of evolution of the brain. If we find that how early relationship with our caregivers shape how we experience others, whether we experience others as kind versus harsh, consistent versus unpredictable, available caregivers, available versus unavailable, trustworthy versus dangerous, that I don't feel safe in presence of certain people. And it shapes how we experience ourselves. So the experience with others shapes experience with ourselves. Is, am I worthy of kindness or love or nurturing? That's where the self-criticism and shame takes place. These early relationships also powerfully influence our ability to feel safe in connection to others or not. Shame and self-attacking get in the way of working effectively with our challenges and emotion. And very early on, we get this cognitive error, if I may use the word, that there is something wrong with me, or I am not worthy of love, nurturing, or kindness from others. However, we have unlimited access to our own internal experiences, but we don't have an access to others' experiences, others' private experiences, as much as we have to our internal states. Because evolution has shaped us to be very concerned about how we exist in the minds of others, how others perceive us, and hence, in response to that, we cultivate shame and self-criticism. So we are set up to self-shame and self-criticism, but and this keeps us in a sort of threat cycle. Now I'm coming to the threat cycle, which is basically how we emotionally regulate ourselves, and where does CFT or compassion fit into this threat cycle. But before that, I just wanted to introduce what Sir also introduced already, that what does self-compassion look like? What does it mean? What does it look like? So Kristin Neff, one of the proponents of self-compassion post Paul Gilbert time, I would say, she said that it has three major components, which is self-kindness versus self-judgment, common humanity versus isolation, mindfulness versus over-identification. I'll come back to it when we practice self-compassion part. Coming to the emotional regulation and the threat cycle, that there are three systems that work with us. One is drive system, one is soothing system, and one is threat system. It's more like fight and flight, or how our limbic brain responds to any threat or anything which we feel unsafe with. In session, what a CFT therapist would ask the client to imagine that which of these circle is bigger or smaller for them, and most likely either the drive system is bigger or the threat system is bigger, but the soothing system for such people is smaller. And the function of the soothing system is to slow down, to soothe, rest, digest, whatever the PNS, parasympathetic nervous system, is responsible for. And the threat system is, of course, fight and flight, and the drive system is that dominated by the feelings of motivation, driven, excitement, and so on. Evolutionary, our mammalian brain was responsible for caring and affection, but as the brain evolved and our cortex and prefrontal cortex developed further to meet the challenges of the growing world, we developed the new brain, which is responsible for planning and decision making. But somehow the old brain, or the bottom-up brain, is connected with safety and security. So CFT, what CFT does is it enhances sort of the abilities of the old brain, which we are already wired for. But to fight with the growing demands of the world, we only focus on the new brain or executive functions and all of that, which I have named that as a tricky brain. That we develop our new brain capacity in response to the demands of the world, but somehow the brain that brings safety and connection and care is somehow getting lost or zoomed out. And here's a tricky brain, here's a demand of the brain, demands on the brain today, and there's an evolutionary brain. And CFT sits with somewhat in the evolutionary brain. Kristin Neff expressed that the evolutionary and neurological underpinnings of CFT is that the mammalian caregiving system is enhanced, that self-compassion activates the parasympathetic, and it secretes oxytocins and right amount of hormones and neurochemicals that promote safety and soothing mechanism, and it contrasts with the threat-based system, sympathetic system, which is fight or flight, which is also responsible for self-criticism. Now, and it also enhances neuroplasticity, strengthens the circuit associated with positive emotional regulation, and dampens the activity in the area linked to fear and judgment. A lot of us confuse empathy with compassion, so I sort of put this slide here to say that empathy is the core idea of empathy is feeling with another person, but for compassion, it is feeling for another person with a desire to help. When we actively seek out to help the other person, it becomes action oriented. When empathy becomes action oriented, it turns into compassion. The focus of empathy is inward, focusing on the feeling the other person's emotion as our own, putting oneself in the shoes of others. But compassion is outward, focusing on alleviating the other person's suffering becomes action-oriented. Now, Paul Gilbert, the proponent of CFT, said that in a compassionate mind training, he looked it at as a multimodal system. And he said that the attributes of compassion are, like I said, that much more than empathy. So it requires us to be sensitive, sympathetic, having a certain level of distress tolerance, empathetic, being non-judgmental, and care for the well-being of the other. And for these attributes of compassion, we need to cultivate the skill of compassion. And to cultivate the skill of compassion, we need all the elements of basically what CBT also talks about is we use feelings, sensation, behavior, reasoning, imagery, and so on and so forth. So I'll briefly describe what the attributes of compassion are. That what is the basically nature of compassion and how do we engage with and prevent suffering. Paul Gilbert identified several attributes associated with compassion. That is sensitivity. What is sensitivity? As a person who is interacting with the client, if we do not offer a right amount of it is self-compassion. It is not just now compassion. It is self-compassion. If we do not offer or understand self-compassion with with our feedback of our biological function, threat system, drive system, and then attune with the client, then we won't be able to just relate to the client. So the attunement is only possible when we offer that right kind of self-compassion to ourselves as a therapist. That's why sir said that it can be tricky, it is challenging, and it is something that is looked at or to be cultivated over a long time. It is not something that I've learned CFT now I'll begin just with it just tomorrow. So it takes time. Like mindfulness is cultivated, just that self-compassion is cultivated over time. So it requires sensitivity, that is opening up to the experiences of pain and suffering. How does pain and suffering look like, and not shying away from that. Sympathy, bringing warmth rather than criticism. Distress tolerance, being able to endure that discomfort and being able to self-soothe also. Empathy, understanding of the emotional experiences, and non-judgmental, moving away from judging or labeling or self-blaming, and caring for well-being, motivation for caregiving and nurturance. So this is how we will cultivate a stronger self-compassionate identity. Now, what does therapeutic relationship in CFT look like? The therapeutic relationship involves that how do we translate and teach the CFT model to the client. I, as a therapist, am a facilitator of self-discovery and curious of all the experiences that the person is having, whether it's to do with pain, suffering, joy, a whole range of gamut of experiences and emotions, and having a secure base. So basically, it's also rooted in the attachment theory of providing secure base to the client. The therapeutic stance that is assumed by the therapist is not just talking, but embodying that sense of calmness, safeness, and patience, so that the trust is built, the playfulness and the respectfulness that you offer to the client. The role of the therapist is to help a client experience the safeness in their interaction with them, to tolerate and feel safe. Once the client is sort of rooted and you embody that safety, the client will open up to face or to tolerate the discomfort of the suffering that he is experiencing. These were the attributes of compassion. Coming to the skills of compassion is so generally when I do a workshop on CFT, I take all the elements and in detail and do exercise, but I'm just here introducing these skills, that how do we bring into the our session. For example, attention, cultivating mindfulness, that whatever is coming up, whatever material is coming up during our interaction with the client, the feeling, connecting with emotions associated with the suffering, the sensory aspect of it, that where do they feel stuck, or when they highly criticize themselves or others, where do they feel that in their body, tracing the body or sensations when they feel shame or criticism or any difficult emotion. Behavior, doing things that are helpful to others, engaging in appreciation or gratitude, opposite to what the client brings in generally when they're suffering. Reasoning, includes perspective taking to determine whether what will genuinely be helpful in this condition when they are suffering, and using a lot of imagery that stimulates particular kinds of emotion, especially the mammalian brain that we talked about. Now, there are two schools of thought that say that, one sir touched about, that this is, and now people are started to practice it quite independently as a model. And one school of thought says that it is not a competing therapy model, that you choose either CBT or CFT. Since it's not a competing therapeutic model and it is diagnostic in nature, it's an emotional process modulator that enhances existing psychotherapy protocols. It can be used with traditional CBT protocol, ACT protocol, or trauma focused, any trauma focused. So, how do we bring in this element of CFTs? I've touched very briefly that during CBT, it challenges the self criticism, that it challenges the dysfunctional automatic thought. There's a compassionate reframing that introduces a compassionate voice as a direct functional alternative response to negative automatic thought, using the thought record that incorporates a self-compassion column. That if this is the thought you're having, what does your compassionate voice tells you? What is the alternate thought that comes out of your compassionate self? The behavioral experiments are rooted that if I'm kind to myself, a lot of times when we are high on criticism, we say that I can't pause, I can't slow down, I can't rest because I will lose out on something. So that's why I said in the beginning that it is contrary to the thought that what if I'm kind to myself, you're asking me to take a pause and be kind to myself, but then I won't end up doing anything, achieving anything. So I'll become lazy. But researchers have shown that the self-compassion actually increases the persistence. Yes, I'm left with 3 slides only. And integrating ACT is we have cognitive diffusion exercises in ACT. So self-compassion facilitates those diffusion exercises. It also allows the acceptance of thoughts and experiences without judging the content of distress. And it is also rooted to the value work that we do in ACT. Same as trauma-informed care, that it reduces shame in trauma. Trauma is closely related to shame. And body-based practices, CFT has a lot of exercises which are body-based, look closely as trauma-informed care. These are some of the techniques that people generally use: compassionate letter writing, chair work, imagery, breathing, etc. So I would say that self-compassion provides the necessary safety and emotional resource for clients to engage with difficult cognitive and behavioral processes. And we would like to position self-compassion as not a luxury item on our laundry list, but as an essential, robust foundation for psychological resilience. And these are the proponents of self-compassion and compassion, or Buddhist psychologists that talk about this practice. Some of them are mentioned here if you want to dig deeper. And these are certain resources that maybe at the end of the session you would like to refer or take note of. Thank you. Which one do you? Just this one. Yes.
Good afternoon, everyone. I will be talking about my reflections of what it was like using a self-compassion based intervention. So what was the process like with emotionally disturbed women? Right at the beginning, I think I'll say I've also had to embody self-compassion, not just as a clinician, but also as a very early career professional who has had the privilege to share this with very senior faculty. So I had to practice it to ensure that I could handle the nerves of if I'm going to do justice to this, so that I could lean into the curiosity that guided me in the process. And I could share the reflections where I would like to talk about the complexity that shows up in the therapy room and how I try to navigate that. So who were the women that I worked with? So I was working with women in the OPD at Ibhas Hospital, which is a tertiary care center. These were mostly women who lacked agency in major areas of their life. So they were married quite young. They discontinued education against their will. They were financially dependent. Came from low socioeconomic backgrounds. Their mobility within their household and outside was restricted. They had very low social support. There were multiple caregiving responsibilities upon them, and they often came to us at a time where the stress, the distress they were experiencing were multiple, and it had been ongoing for several years. And a lot of the complaints that they came up with were, in addition to the frustration, the anger, the sadness, was also very somatic focused. But what were the clinical realities like? So there was minimal family involvement, but very high expectations from the treatment. Both the family and the client would have naturally a very limited understanding of what mental health is, and there would be a sense of urgency with which they would come to the OPD regarding symptom improvement. And they would often question why is it that the client needs to come for multiple visits when the client on the surface looks fine, ठीक ही तो दिखती है, क्यों बार बार बुला रहे हो आप? And then later on, the women often were coming alone. So there was then reporting feelings of loneliness and frustration that I always accompany my family members, but no one cares about me, and I have to figure this out by myself. These were tertiary care referrals, which meant the follow ups were very episodic, usually once or maximum twice a month. There was often also a lot of irregularity in the sessions because these clients would be coming from very far off. Now, this entire context, it shaped my journey towards why I would like to use self compassion. Because by the time they came to me, there was chronic stress, there was emotional saturation, there was low agency existing in the life of the women, there were ongoing stressors, and therefore also the emotional vocabulary for them to be able to understand and share that with me about what was happening and how it was impacting them was very limited. So, generally, the methods, therapeutic practices, which would expect them for regular follow ups or some kind of extensive homework or self practice in between sessions were often quite impractical. So was at this point the link between the cognition and the emotion was also not immediately accessible to them. And one thing that stayed and struck me is that across diagnostic categories, what was pervasive was the theme and element of self criticism. The way they spoke about what happened to them, the way they understood it, and there was so much guilt and so much shame that was attached to their suffering, almost as if there was something questionably wrong with them. So they would come and ask me, क्या मैंने कुछ बुरा कर्मा किया है, मैंने कुछ पाप किए हैं, क्या मैं इतनी बुरी हूं कि मेरे साथ इतना सब कुछ हो रहा है. And conceptually, I was also looking up and reading on Kristen Neff's model of self-compassion, which was the core model that I have followed in my work. Common elements already described by Dr. Prema and Dr. Uday. And cross self-criticism is a transdiagnostic factor that we see across mental health conditions, and it has an impact on the kind of outcome that we see in the work that we do. Kristen Neff targets this very internal critical voice as a target for intervention, and I wanted to explore that. Given the context of the somatic distress, the cognitive fatigue, and the lack of emotional vocabulary at the time they came to me, I naturally, if I'm being very honest, I had my apprehensions about using this in therapy because I felt, what if it's a very soft concept? What if, they will laugh at me or roll their eyes at me or think that I'm not in touch with their reality? And well, they did. Some actually did roll their eyes at me. They laughed like, "Madam, आप तो शहर के हो, आप तो पढ़े लिखे हो, आप तो ये सब बोल सकते हो, but you don't know what that looks like for us." And that was a very real hesitation. I was also very cognizant of the differences in the kind of background that I came from and the power dynamics that would influence in the therapy room. And I wanted to ensure that at no point I am minimizing the factors that have contributed to the distress that they're going through, and I'm not ignoring the context within which what is happening to them and the very environments that they're going back to. And therefore, my concern was that am I going to risk implying that the sole burden of change was on the woman and invalidate what was happening around her? So, how I prepared for it? This
I wouldn't say this was a linear process. It is still an ongoing process and will continue to be ongoing as long as I'm a clinician. But it had several overlapping factors that I looked at before I formally started working and introducing it. So my personal practice, of course, included reading what I've already mentioned, and also noting in between sessions. There was a lot of journaling that I did, a lot of self-compassion exercises that I did, so that I could actually look at what worked, what didn't work, what fell flat, where I was left wondering how I should respond in the moment. Uh, what was my understanding of empathy and of accountability and of effort, and how I was bringing that as a therapist into the room, and how I was therefore interpreting how the client was responding to me. And all of this is something that I took forward with me to supervision, which was very, very central, because there were continuing, regular, ongoing conversations about at what point, when the conversation is becoming emotionally saturated, do I let the person continue? Do I let them speak, or do I redirect the conversation? Right? How do I balance that? How do I, bring in the possibility of some micro accountability that they could look at without angering them and making them feel that, आप नहीं समझ रहे हो, मैं क्या go through कर रही हूँ. And then, of course, Crystal Meth has come up with certain interventions in terms of how it can be introduced in the first initial session itself and how to take that forward. But we were also looking at what is the cultural relevance of it and how we can contextualize it and how we can adapt it. So, and I'll speak more about this as we carry on. When I first started looking at this concept and introducing it, compassion was not an unfamiliar territory entirely. For a lot of these women, they were practicing compassion, but it was compassion that was outward towards their kids, towards their husband, their parents, their in laws. So the barrier wasn't the absence of compassion in the women, but it was the direction of it. So there was a lot, it was never modeled for them that this is something that you could do for yourself as well, without a lot of shame, without a lot of guilt attached to it, because sacrifice and endurance is something that is looked upon as the good thing to do. And being gentle to yourself and being kind to yourself, taking time out for yourself, is something that can be framed as very indulgent. And therefore, for me, the way I reframed this and the way I'll actually talk about this a little more as we go ahead, because I see we have limited time. So, what unfolded in sessions? Let me quickly go through this. Now, see, translating all of this understanding and supervision into the sessions was a very difficult experience for me as a clinician and also as a person sitting across that kind of suffering. One thing I consistently noticed was that a lot of the distress that they experienced was very relationally located. मेरे हस्बैंड ने ऐसे किया, मेरे इन-लॉज ने ऐसे किया, मेरे बच्चे मेरी बात नहीं सुनते. But what it was like for them emotionally, how it was impacting them, what would they like to do differently, that wasn't existing. So, and also, unka kaam hai na, I have taken care of them all these years. Now they should take care of me. Another thing over here is there were long narratives. They would not pause in between to give me any space to speak. At the same time, they would say, okay, मैं समझ रही हूँ क्या बोल रहे हो, but how does that make the pain go away? How does that make what I have gone through go away? How does that erase all of that? And I still have to go back to where I'm coming from. Then a lot of them will also hand over the agency to me and expect a very prescriptive approach. आप कुछ भी करो, मेरा सिर दर्द, मेरा बदन दर्द हटा दो, because it's only this that is causing the problem. ये चला जाएगा, I will be perfectly okay. आप मेरी फैमिली से बात करो, दे आर सिटिंग आउटसाइड, वे मेरी बात सुनेंगे नहीं, लेकिन आपकी बात सुनेंगे तो सब ठीक हो जाएगा. Then the whole I'm not like you, we're different, something I've spoken about. Finally, what's the use? My pain will not go away, so why should I do this? The people are not changing. So what were the therapeutic entry points? One was framing self-compassion, and I think this is where I will actually somewhere wrap it up. One was functionally framing it. So, what is it that the women already value? All of them who came, who had children, said that the only reason for us to take care of ourselves is that, we have children to look after.
And they're the only motivation for us to not give up. Not to अपने आप को, I would have run away or I would have done something to myself because my life is over. So looking at, okay, it's not about maybe taking care of yourself, but taking care of the things that you value, that are important to you, and building your emotional stamina for you to continue doing what is important to you. Which in this case, let's look at caregiving. And that was an entry point for us to start the conversation. And then also looking at validating as a clinician what they have gone through and also discussing with them, not can you be kind to yourself? No. Can we look at certain micro possibilities during the day and during the week where you can take out time to do things that you value and more where we can start that from. And then it was also something that I modeled through the pacing, through my tone, and through co-regulation when the emotions got very intense. And therefore, I would say that even in constrained realities, self compassion, which was my initial apprehension, is something that is very valuable because while yes, they could not leave their environments, we need to understand that agency can coexist with hopelessness and powerlessness. And therefore, our task is to validate one and invite the other. And in my conclusion, I would say that self compassion is a clinically defensible early intervention stance, including in constrained realities, which, when introduced carefully in a culturally adapted, supervised manner, it enables intrapersonal repair and makes deeper work possible. Thank you.
Now we have seen two presentations. One has explained what compassion, self-compassion and the therapeutic approach in using self-compassion is. Also explaining the scientific, which is neural basis of self-compassion, and also that is the one. Second, Jasleen has told us as to what she has felt right from the beginning, from planning to implementation, and that has given us a lot of information as to there are several challenges which need to be considered before really going into the practice of self-compassion. As now the potential of self-compassion as a therapeutic entity is unquestionable. There are a lot of potentials. Now we are not here to analyze that. We are here to just look at the challenges which one can face and cannot be ignored. I think.
Yeah.
Can you help me in finding the slides? The challenges which are there is based on largely based on the personal experiences and reflections shared by Jasleen here, and some of them are assumed because there are many component of self-compassion as therapeutic technique shares the common element. It's not specific to this particular.
Excuse me, Dr. Uday. Just a minute. There's a word from the organizers. We kind of overshot our time and we'll have to proceed for lunch quickly. So if we can wind up in about 5 minutes, then we'll be good to go.
See, one major challenge is to understand the concept and make the client understand the concept. I think that is something which is very, very great challenge. The second challenge is the identification of relevant component and variables, right? And assessment. We do not have really many methods of doing that. So that is equally a challenge. Preparation of client, as we have seen the experience which Jasleen has described, it's not easy for the client to understand and get into the line of the required involvement. So these are, and naturally the competence of therapist It's not just saying that one has to be compassionate to oneself. I think it requires particular way of conveying that, and this also requires a lot of practice, which I think Jocelyn tried to do that earlier before starting the work, to experience so that you can explain the concept better. There are various threats also which one can identify. One is definitely the temptation of the new young therapist. It looks very attractive to use these kind of therapeutic approach, and if you plan without enough preparation, just considering that okay fine, let's start, things will fall in place, I think that is very very damaging. And the perceived fear in the practitioners, that was evident, right, in Jocelyn's reflections, whether I'll be able to do it, what if I do it wrongly, what if it doesn't work. I mean, there are a lot of fair elements which are the threats. The opportunities are tremendous, right? One is it has inherent therapeutic potential, the concept. It is very close to cultural interpretation and cultural value system, I think, and that makes it, an element which can be easily practiced if somebody is seriously doing that. The evidence of acceptance is available. There are a lot of work which has been reported, either in the form of observation or the systematic research that gives us a lot of evidence to accept it as therapeutic approach. And here self has only resource which are used. You do not require to add many other resources or materials. So I think that is also gives us the opportunities are enhanced. It is feasible to practice, right? Value laden, and it has very strong association with universal values, which is essential component in current understanding of mental health. And we have a lot of existing materials. So these are the opportunities. Now, if we look at the challenges, the threats and opportunities, and strike a reasonable balance and start practicing, then only this can be practiced. Not exactly as the Paul Gilbert has given us, compulsion focus therapy, or as described by Kristen Neff. We can have our own indigenous model of practicing it and evaluating the impact. Thank you. I mean, this is something which we wanted to bring for consideration. Thank you.
Victoria, you want to decide?
Thank you for these excellent presentations. They are so thought-provoking and really interesting. And this is such a sort of cutting-edge area, really. So it was really good to hear your thoughts and hear about how this therapy is, can be integrated with other approaches, that it's really a complementary approach that can really enhance what we do. But also, I really appreciated your remarks about what is the entry to that for the client, because that can be the hard bit, really. And so I thought your observations were very good about how the entry is, but also the reactions to it, right? It can sometimes take a while for them to understand and get round it and round this sense of guilt and sort of self-criticism that comes so naturally after so long. But also the practices that you can take as a therapist in terms of preparing yourself for it before and between sessions. And I was really struck about how that leads to a much more authentic, experience in terms of what you bring into the place. So I really, really appreciated this talk. I don't know, do we have time for maybe one question?
Maybe I know. Yes.
I have a question.
Yeah, please.
So, if we talk about patients who come with attachment traumas, And how do we apply this with them? Like first, initially, I understand we'd have to work upon the cognition for them to actually be able to feel it. So my understanding is like, how would we go about this process with them?
That's something.
Lot of,
That is something. It requires explanation.
One or two words. But as described by just there has to be enough pre-intervention assessment as to whether this is going to be a suitable approach or not. If it has to be suitable, what kind of modification it requires, where one can directly address the self-compassion part, or there can be some other important issues which can be taken care of first and then in between. So the process of how to go about requires a huge kind of explanation, and it's not easy to describe.
Yes, I think you could take up the talk over lunch with Jasleen or with Reena a little further down, because it's something that requires quite a lot of extensive explanation. But thanks for the question. Can I please raise one question which everyone asks me when I talk about self-compassion? That is there a difference between self-compassion and self-indulgence versus selfishness?
I could have said that when I described challenges. I think differentiating self-compassion with similar sounding concepts. It is not being selfish. It is not being narcissistic, right? It is not it is simply to be kind to oneself, right? And no, what you do, suppose the small child in the family gets ill, what kind of care and attention is provided to that person? What kind of comforting exercise you do, whether that is possible with oneself or not. In fact, this is not something which is our usual practice in life. It's something like rewarding oneself. See, we do not practice self-reward too much, but this is a very effective method of modifying one's own behavior. Similarly, giving attention to oneself or being kind to oneself appears something to be laughed at, smiling matter. But this has huge potential in it, provided somebody understands it and applies. And application does not require, whole lot of technical or mechanical skills. It's a very simple. But the most important part is to understand it and differentiate it from many concepts which relates with the self.
Right. Thank you so much. Thank you so much. That's just such a wonderful session we've had on self-compassion. I think it's something of interest to a lot of therapists and a lot of good pointers that have been raised, which all of you can grow with. And I think with that, I'd like to close the session, but we can all go for lunch. I'm sure there are a lot of indicators, sensory indicators about the impending lunch. Okay, thank you. Thank you all so much. Thank you. Yeah.
The same after the program.
Oh, well, you know, we didn't show. It's often lunch, right? Wonder will the session start at?
Good afternoon, everyone. We are starting with the workshop on the topic limited reparenting in schema therapy. I would like to invite our chairperson, Thomas Kishore sir, on the stage and request Dr. Uday Sinha sir to felicitate Thomas sir and also request him to be the co-chair for this session. Yes, yes. I would like to introduce Thomas Kishore sir. He's a professor at Department of Clinical Psychology in MANS with the background of PhD and MPhil. His areas of interest are child and adolescent mental health. Now, I would like to invite our speaker, Dr. M. Manjula ma'am, on the stage. She is a professor at Department of Clinical Psychology in MHANS, Bangalore. Her professional background are MPhil and PhD in clinical psychology with area of interest in cognitive behavior therapies, third wave therapies, schema therapy, process research in psychotherapy, mood, anxiety and suicidality, personality disorders, stress trauma disorders, sexual dysfunction and youth mental health. I would like to invite Thomas sir to please felicitate Manjula ma'am. Now I would like to invite our next speaker, Dr. Priya Puri, on the stage. She's a clinical psychologist and entrepreneur, certified trauma specialist, providing holistic healing, expert in trauma-informed care and schema therapy, founder and chief clinical psychologist at the Healing Space. I would like to request Thomas sir to please felicitate Dr. Priya Puri. Now we would be beginning with the workshop.
Good afternoon to everyone. It is indeed my honor to really chair this session because, as you might have seen from my CV, I have nothing
remotely to do anything with the schema therapy, except guiding Dr. Priya, co-guiding rather, and learning it more from a theoretical point of view and applying it in a very limited cases. But however, that you might be aware, like when we talk about institutions, senior colleagues who have done certain areas of work in behavior medicine, that you would be very familiar that there is a strong team from Enhance since that time. And in the current, the colleagues we have, among them, Professor Manjula, and the entire team conducts series of workshops related to CBT, mindfulness, and even schema therapies. They are the stalwarts, literally, because both in terms of the experiential point of view and providing services, and there is a bulk of research that has come from the team, particularly Professor Manjula. Therefore, I'm sure it is going to be quite an enlightening thing because we know what we read in the books is completely different from when we hear it from the experts, and here we have one such expert. So therefore, it's my honor. And then Dr. Priya Puri, who has done her PhD, the joint guidance was on borderline personality disorder, wherein she explored the schemas and how they can perhaps give us some insights into how the psychopathology is there. And after that, while my knowledge stayed there, her experience and her pursuit has continued, and then she's much more knowledgeable in this area. So with this introductory remarks, I hand over the mic to Professor Sin to provide any comments. Otherwise, I should be enriching and interactive session in this workshop.
Thank you, sir. I will request the presenter to begin their presentation.
My skills, you can just name this. Is there technician. Technician. I thank the organizers for giving me this opportunity to conduct this workshop. And 1.5 hours was a very, very less time to cover the topic, but we thought we will do whatever is possible in 1.5 hours. And I thank the chairpersons for the warm welcome and the introduction. So what we are going to focus in this workshop is basically the we will not be able to go into the theoretical aspects of the schema therapy, and we are mostly focusing on limited reparenting. So that is one of the important aspects in schema therapy. So I can say that that is the core of schema therapy also, because we use Socratic questioning in CBT, and we use the core schemas and the schemas in the CBT, like that. In schema therapy, basically the important things are like things which are slightly different from CBT is the modes that we use,
and then the role of the therapist, that becomes very important. So these are different from like what is there in the CBT, and the stance of the therapist is also slightly different in, or I can say it's largely different in schema therapy compared to the CBT. And to practice schema therapy, one needs to be trained in CBT, because the schemas and distortions and behavioral and cognitive methods that we use in CBT, it is used in schema therapy also. So it is also a cognitive therapy, basically. Yeah, so you know that the schema therapy, developed by Jeffrey Young, and after that there are a group of researchers from Dutch, and know that the Dutch therapists and the researchers, and they're expanding the schema theory and the schema modes and the mode models, and people are coming up with a lot of specialized schema therapy for different populations, like forensic population, for children, for couples, and there are different kinds of, and for different disorders like OCD and depression also, there are schema therapy approaches that are coming up, and there are briefer modules that are coming up also within the schema therapy. So looking at, like I said, I'm skipping a lot of theory part of it, so I'm jumping straight into the assumptions of schema therapy, but then the focus of the workshop is on limited reparenting. So I'll see that how the limited reparenting is something which is used across the therapy. So that is what I will be talking about. And Priya will be covering the challenges and each of the components of the limited reparenting itself, and then the challenges and how to address those challenges, because this is something which is slightly different from the therapeutic relationship that we establish in any other therapies, because a lot of emphasis is given to how do you actually do it, when you are using schema therapy across a particular within the therapy, as well as across the different kinds of clients, like how it manifests and how do you handle the therapeutic relationship. So coming to the assumptions of schema therapy, that modes is something which is specific to schema therapy. They talk about the modes as something which is there, like which all of us use, and it is triggered across different kinds of situations, like how all of us have some distortions, and then it just manifests across situations, and how we have schemas and that gets triggered across situations. Same, like modes also get triggered and it manifests across all of us and then across situations. Okay. But then, like, how do we manage or balance it? When the mode is activated, what kind of coping methods that we use, and how do we balance it, and how quickly we come back to the healthy mode? That is something which determines whether we get disturbed or not. Same like CBT, like that all of us have schemas, they get activated, but then how do we manage it, and how quickly we are able to balance it with a more balanced belief or a thought? That determines whether we are getting distressed or not. In chronic problems, what happens is that the schema modes tend to be extreme, and there is a frequent switching that happens. Okay, so they quickly switch. Sometimes they get stuck also in a particular mode, or most frequently they are using a particular mode. So that is when it becomes dysfunctional. So in therapeutic relationship, by meeting the core needs of the person, we can directly heal the modes. So one of the goals of schema therapy is healing these modes, healing these unhealthy or dysfunctional modes. That is something which is one of the goals. So finally, what we want to achieve is that gradually you will have to help the healthy adult mode to develop more, and also to have secure attachments outside the therapy, and also to reduce the self-defeating behavioral patterns. Okay, so these are the goals of the schema therapy: to connect to the core emotional needs of the person, and then weaken their maladaptive coping modes. Coping responses are the modes. Support the schema healing, and to help patients strengthen their healthy adult mode. and eventually to get their core emotional needs met in the day-to-day life. That is very important because day-to-day life, these schema modes are getting activated across situations that is causing a lot of dysfunction to them. So before I move into how exactly that we formulate, in schema therapy, because without understanding how do we formulate, then it becomes difficult to move further and see what exactly happens in the therapy. So I'll just give one case example. This is one 29-year-old graduate. She's a health professional and she's from middle class socioeconomic status, and both the parents are working in they have a petty shop, and she has a younger sister, and client has, like, she's been taking care of the younger sister from the time that she remembers. She was as the youngest 6 years, 7 years old. She's been taking care of this the sister, and after she grew up also, she was supposed to take care of the house, cooking, because both the parents were working in a shop. So they will leave early in the morning and they come late in the night. So that is why, like, she is responsible for the household things. And like, she could not do many things that the children of her age could do, because she had to take a lot of responsibilities. That parentification was happening, and then know that she was not allowed to play or go for school trips or like wear good clothes that she wanted. Nothing, like, she could not do many of those things. And whatever happened at home, like, she was blamed for that. Like, that even if the sister makes a mistake, that she has to take that responsibility of not actually monitoring the sister. And another problem was that the mother was actually she was very young when this patient was born, and then she always felt unhappy about having this child, the girl child, and because, like, one, she was young, and then she was afraid that she will look old because she has a child at an early age. So she never used to encourage this girl to go with her or walk with her, thinking that, like, people will think that I'm old. That was her fear. And also, she was an anxious person. Like, she was not able to make decisions. So she used to become very anxious, and then whatever the small problem, she'll share with all relatives, and people used to interfere in their family matters, and most often with this girl also. Like, whatever used to happen with this particular client. So as a child, you can see that she felt neglected, and she was body shamed because she was growing up faster also, and also she was blamed that bad things are happening because of her, and like that. And there were problems in terms of the financial problems, mainly because the father was not good at making decisions. He used to make a lot of wrong decisions, and this girl was responsible for actually monitoring the father's financial investments and his problems also. So she took up a lot of responsibilities to begin with from the childhood, and she had to provide that emotional support to sometimes to the father and to the mother, and the problems also, a lot of responsibilities she was taking. So when she was an adolescent, she got into a relationship with a relative who was older to her. Mainly because he was providing a lot of moral support and emotional support to her, but then he was in a way physically molesting her. So there was some sexual molesting that was happening with him. But that she did not realize that whether it was correct or not, because she was getting that emotional support from him. Ultimately, when the relationship broke up, the mother blamed the girl. When she got into a relationship, she blamed her, and when she was out of the relationship also, she blamed her. So, like, most often the mother used to blame her for wrong decisions that she was making. So when she came, like, when she presented to me, like, she came with a lot of symptoms of depression, like tiredness and not able to sleep properly, or sometimes excessive sleep, and then perfectionism, binge eating. So these were the problems that, and also having to take a lot of responsibilities at home. Like, she was burdened, and most of the time she used to complain that she is tired. I cannot do anything more. I'm tired. I'm tired of taking these responsibilities. And she was not enjoying anything, although she was working when she see me when she was in therapy. But then she was not able to buy anything because she felt that I don't deserve and that I cannot enjoy anything. So those kind of beliefs were there. And also she was very afraid of parents taking care of the household responsibilities. But that she has to continuously monitor what the father is doing and his financial commitments, and mother would always want the small things to be discussed and solved at home. The smallest of the things that she will call her and discuss with her, and she had to problem solve most of the time. So in schema therapy, the formulation goes like this. Like if you have seen the CBT model and the versus the schema therapy model, here you can look at the early experiences. It is similar to CBT, like parentification, constant criticism, blaming. All these things are like the early experiences which resulted in a number of schemas basically. So and then I have given the modes here as well as the coping modes. So this side you can see that there are parent modes and there are some child modes, and here on the other side there are coping modes. So because of these experiences, how she has developed different kinds of modes. So the parent modes includes punitive and demanding, invalidating parents, and then child modes include the mode of helplessness, the helpless child, abandoned child, angry, lonely, anxious, and dependent child modes. And this is developed because of the neglect from mother and rejection and another blame that she had to take from the parents as well as relatives and all that. And then how is she coping with it? Mostly she is coping by detaching herself. That is like feeling tired is one of the ways of coping with things. That is a detached protector mode. Like it's one of the detachment modes. Going numb, low, avoiding facing parents or any other performance situation she used to avoid. And excessive sleeping, excessive eating, sometimes smoking, drinking. So these are all again detached self-soother modes. And when it comes to coping modes, we talk about one is the avoidance modes, and then the compliance or surrender modes, or it is the inversion modes, like you do the opposite, that is overcompensation kind of modes. So inversion modes includes perfectionist, over-controller, and approval seeker. Like she was very sarcastic in doing things. When she is not able to do things perfectly, she would blame herself, and then she will avoid things and procrastinate. All those things used to happen. And because of this, like she will postpone, like she will not make any decisions, and then she will lose interest, and she had a lot of difficulties in interpersonal relationships, and there is no clarity in terms of what she wants to do in future. Okay, so if you look at the healthy adult mode, there are certain things which are healthy in her, and she was able to do many things, and she was able to do well in her academics because she was able to manage certain things well. And she was hardworking. That is one of the part of her healthy adult mode. And then she was helpful. She was a very helpful person, both to her friends and family members, as well as to the patients. Like she was a medical professional, so she was very helpful doctor that way, and she was very empathetic. So these are all the parts of the healthy adult. Okay, so now coming to so if you ask me what are the goals in this particular client, you can say that that you want to change these vulnerable child modes into more healthy modes. That is something which is very important here, the goals, as well as the coping modes that she is using. It is not helpful for her, so we have to change that also, and also some behavioral patterns in terms of avoidance that she was using, as well as getting into frequent relationships. That is something which I have not mentioned, but it's there in the slide. So she would get into the relationships, and then she will have disappointment there, and then again she will go into this depression, again she will get into a new. So this was something which was happening, and always the mother would intervene, and she will share everything with the mother also, and the mother will blame her, and this will go on. Okay, so that was another the behavioral pattern in terms of relationship pattern. Behavioral pattern mainly includes the sleeping, oversleeping, overeating, binging was something which was there, and sometimes like watching, too much of Like she will binge watch also. That is also one of the coping methods, that behavioral coping methods. So coming to the core components of schema therapy, it is like, first of all, one has to present the mode model. You know how we have the CBT model where we mostly, in the formulation we emphasize on the cognitions, the core schemas and distortions and all those things. Here, like, the emphasis is on modes. Okay. And the current mode dictates what techniques to be used, like what kind of modes are manifested in a day-to-day her functioning. So that is something which dictates what kind of techniques that we have to use. Limited reparenting becomes very, very important, mainly to meet the unmet emotional needs of the client. And then the foci of the treatment is, one is the past. Unlike CBT, that we only work on the present, but in schema therapy, we also work on the past. Okay. And the therapeutic relationship, the present and the future. So these are the three important, the main aims of the schema therapy. So the three channels of the techniques would fall under these three. One is experiential, cognitive, and behavioral. So what is additional here is the experiential methods that we use. Okay. Healing the vulnerable child modes and strengthening the healthy adult modes, like I said, so that becomes one of the goals. So we use a lot of experiential techniques for emotional change and behavioral pattern breaking. So we want to change the behavioral patterns. So what is used to address these three things? That is the past and the future. So generally we use, for all these things, the past, present, and the future, we use certain methods to address the feeling, certain methods to address the thinking, and certain methods to address the doing, that is the behaviors. Like I said, the three important things: experiential, cognitive, and emotional. Three aspects are addressed here. So for feeling part of it, that is the experiential part of it, we use a lot of role plays, we use imagery, methods, and then limited reparenting is to again heal those or provide those emotional needs. And then empathic confrontation within the limited reparenting, we will be elaborating on what exactly is done in limited reparenting. We use a lot of chair work is used, two chair technique or multiple chair technique. So we use chair work, and for future also the similar kind of methods are used. I am not going to the details of it. Yeah. So for the cognitive part of it, we use experiential methods as well as the cognitive methods, that is called Socratic questioning, cognitive restructuring, all those things are used. So coming to the stages, that is, the first stage is bonding and stabilization, the second stage is schema mode change, and the third stage is autonomy, like you want to make the person independent. So that is the final stage. And it's a transdiagnostic therapy like CBT, because you can use it across different diagnoses, and the diagnosis has nothing to do with the schema therapy. So the phases includes, first phase would be assessment and education, and here we will assess the schema modes, and then the coping modes, and then and take history, and then we come up with the mode model. Okay. So then once we have clarity on the mode model, then we move to the next, that is the safety and bonding. Here mainly the therapeutic relationship becomes very, very important. Then the schema mode awareness. First of all, identify what modes are there and how do you want to name it, and how do you want to recognize it, and how does it manifest in a day-to-day manner. So all those things will be the next phase of it. Then schema mode management, here that you want to look at what are the strategies that they can use to manage their modes, and how do they identify the modes, and what do they do. And the schema mode healing, that is, how do you heal those modes, like the vulnerable child modes and the parent modes that the person has. So when I am talking about parent modes,
It is the modes that the person has developed over the time. That self-criticality or punitiveness or no, the high demands placed on oneself, all that is coming from the experiences that the person had. So those become the parent modes. Actually, the modes that the person is having, and they are actually using those modes. Okay. So when they talk about, like, how useless I am, I'm such a failure, I can't do anything, even the small things I can't do properly. So these are all examples of the critical parent modes, like that. When that mode gets triggered, then they think like this. Okay. So the modes includes the thinking, feeling, and behaving. All the three components. That becomes modes. Okay. So finally the autonomy phase, wherein that they have to incorporate mode, the more of the healthy adult mode, and they have to function in that mode. So that is the autonomy phase. So what are the things that to be assessed when we are doing the case history and the initial assessment? We have to look at the presenting problem, like to identify whether this person is suitable for chemotherapy. First thing that we have to take the history and look at the symptoms and the family history, the relationships, the biological factors, significant memories. Sometimes they have a lot of very strong memories, trauma kind of memories, and they just keep going back to that. And chemotherapy is something which is used with the trauma also. And it's found to be very effective, and now imagery rescripting itself has become an independent therapy for PTSD, trauma, and memories. Okay. And we have to look at why now and what kind of therapy experiences that the person had, and what is the expectation from the therapy. So these are the things that we have to look at. And strength of the adult self, like what are the healthy parts in this person, the healthy adult part. And dysfunctional pattern identification. So is it that there are patterns which are repeating itself over the time, and what are those? So for that we have to take focused life history. So this is an interview. What we do is basically that, I think in any psychotherapy we do this, that we take the whole history and then we look at what are the patterns that are repeating. Okay. So now we link the presenting problems to the life patterns. And say, like say for example, the relationship problems or the difficulties that the person is having, similar kind of relationship problems. That's the pattern. So we look at what are these patterns and find the emotional links. How is this related to the past experiences, the childhood experiences, if it is related? Okay. Identify schemas. Is it that the similar schemas are running through all these difficulties? Okay. So these are all the patterns that we identify, and childhood origins of the schemas. Now in this case you know that there are childhood origins. Okay. And how are they linked to the childhood origins, the past experiences, and why this person feels so insecure, so lonely. Okay. And why she disconnects, or like she avoids and she numbs sometimes. Why is she doing that? Okay. So the behavioral patterns, the same way, like we look at all these patterns. And the therapeutic stance throughout the assessment would be like warmth and being present and being able to tune to the emotions of the person. That is very, very important. That the therapist, it is very, in the sense that it is very engaging emotionally to the therapist also. That you have to be emotionally invested when you are in the sessions. And also, like one should be able to link the past and the present. That is important. Respectful, transparent, sometimes being honest, not sometimes, it is most of the time you have to be honest in terms of your feelings, and sometimes the kind of the thoughts that is triggering during the sessions. You may have to give a feedback, like when you're talking about this particular thing, or when you talk in this particular way, I also feel anxious. Okay, so I sometimes feel helpless when you are narrating this kind. So it is like you are little transparent when you're talking about your own emotions and how it is triggering certain kinds of schemas in you. Sometimes certain kinds of emotions in you. Okay. So being trustworthy and balanced is also something which is important. So the other important things are triggers for the early maladaptive schemas. Okay, so this is something which you will have to see, like when are they getting triggered and what are the coping styles and what are the responses. Say for example, when the patient is feeling or the client is feeling helpless, what are the triggers that are getting triggered in that person? And what are the schema modes? Once she starts feeling like that, or that the sense of rejection, sometimes the vulnerable child who is feeling rejected. So when the sense of rejection, that is the schema that is getting triggered, what does she do? What is the mode that gets activated? Is it that she goes on binge eating or she goes off to sleep? So it is all avoidant modes. Okay. So you'll have to look at what are the modes that are getting triggered and assess the temperament also. Like certain personality characteristics also can influence the kind of the modes that are getting activated. Core cognitive distortions, and we also use experiential techniques for assessment. It is not only for therapy, but during the assessment itself, you can use the experiential techniques, that imagery. Say, for example, the client is reporting a feeling of helplessness in a particular situation. So yesterday this particular thing happened and I felt very helpless. So you want to know whether that is linked to the past. Okay. So you will want to know whether she had similar kind of experiences in the past. So what you will do is maybe like you will hold on to that particular situation, go into the details and ask to give the details of what exactly happens in the body, what kind of thoughts goes into the goes on in the mind, what kind of feelings that the person has, and what kind of bodily experiences associated with the feelings, and then link it to the past situation where she felt in the same way. Like maybe imagery you can use. You can ask the person to close the eyes and then feel the same thing when they're recalling the yesterday's incident, for example. Then like you will go back and hold on to the feeling and then go back in memory and remember the similar feelings that you had in a particular situation. So they will go back in memory maybe as early as possible. If they talk about 10 years before, and then maybe you can ask them like what is the earliest memory that you can think of. So that is the affect bridge, that we hold on to the emotion and we go back in the memory. And then you will find that similar kind of a helpless situation that happened in the childhood. Okay, maybe that the parents are fighting and the child did not know what to happen and the child was blamed for some reason. Child was not able to understand what exactly is happening. So something like that. No, you will get those experiences in the past. So this is assessment basically. You are just using the assessment to identify what exactly are the situations similar to this and what may be the early maladaptive schemas and what modes. So you will identify those things. Yeah, and sometimes you can set up dialogues also. Like in this particular situation, you started thinking like that, and in a different situation, you were thinking like that. So what do you think is happening? Like you think differently in that particular situation. So you are actually trying to understand the modes. Like is it that the critical part is talking at that time, and at this time, like something which is saying that you give up everything and you don't do anything. That is the avoidance part that is talking. So something like that. So you can set up dialogue so that they know that they think differently during these different modes. Okay, so the dialogues also, chair work also can be used as assessment method. Yeah, so what happens after the assessment is that you identify modes and you identify the coping modes and the child modes, parent modes and all those things, and then connect to the emotions and connect to the behaviors and how they handle different situations, and also look at what stage of change the client is in, because whether the schema therapy will work or whether you can start, that will guide you. Okay, sometimes they are just not ready to for any kind of schema therapy, like that you will be able to identify that basically. So then you cannot start. Maybe you have to delay it and then start. Okay, but most often, like people they're ready. Most often, yeah. So you'll give a feedback on assessment and the current manifestations. Like this is the model and how is it manifested in the current scenario. So when we are talking about the modes, it is also important to keep in mind that the kind of the modes that Young uses or Dr. Arndt's uses, you may not use the same kind of terms. You can use their own terms. Like, they may want to call this helpless child as something. Okay, so you can use that name. Similarly, the parent mode, they want to give some name. Or to this coping mode that they want to, aggressive, angry, a person as a coping sometimes, overcompensation mode, that they want to give some name. Okay, so you can use that name. It's not necessary that you'll have to use the same kind of names. So how do you assess the suitability for the schema therapy? One is the capacity to describe internal experiences. That is very important. If they are not able to, describe, then you will not be able to do the schema therapy. Willingness to share the past. Some people just don't want to work on it. They say that, no, I am not comfortable. I don't want to work on these experiences, the trauma experiences. They know that it is influencing, but still they are not ready. So they say that I just don't want to work on it now. Okay. And they have to commit time because it takes a longer time than your CBT. That is why they have to commit for at least 6 months to 1 year time is required. And one therapist is better. That the therapist change is not going to be helpful because therapeutic relationship is very important here. So where you can't apply the schema therapy in major crisis situations, you will not be able to. Psychotic symptoms, severe and untreated axis 1 disorders like severe depression and all, you may not be able to because they are just not able to process any information. So you will not be able to use. Abusing drugs or alcohol because they are numbing, they are avoiding. So you can't, they can't process. So you will not be able to use. Situational problems. It is situational problem. It is not a long-standing problem, so you can't use. So most often schema therapy is used for chronic problems, long-standing problems. This is one of the criteria that we keep in mind because we are looking at schemas and modes and patterns. Okay. So the first stage is bonding and stabilization. Here, like I said, one therapist has to complete the therapy. And that in any other therapy, we will give the contact of the therapist. And nowadays, people use different mobiles for giving to the clients the numbers. They use different numbers, so you can share those numbers when they can contact, how they can contact, and because the stability and the constancy is something which is required. If they are in a crisis situation, they should be able to tell you something or they should be able to contact you. So that is where this relationship is little deeper than compared to other therapies. Okay. And so the therapist also will ask that how they feel with the therapist. How the relationship is and how do they feel around the therapist, and this is something which is important as a feedback from the client also, whether the client is feeling comfortable. So emotional presence and the co-regulation is very important. You are there with the emotions of the person, you are helping them to handle the emotions. Okay, so the experiential methods facilitates this. So that is where they feel that the therapist is there with them. Okay. Yeah. So the important qualities of the therapist for limited reparenting is one is patience. Okay. So a lot of time that you will have to spend, and maybe you can't sometimes stop the session at 1 hour, sharp. You may have to extend the therapy sessions. Supervision for the therapist is very, very important because they have to become aware of their own dysfunctional schemas and coping styles. Sometimes if their schemas are getting activated, they may use certain kinds of modes, they use certain coping modes. Okay, so that may be interfering in the therapy process. Maybe they're too strict or they're expecting a lot of things from the client and they become one demanding parent. So it should not be like that. So they should become aware of their modes. Or They don't set any limits at all. They become very flexible and no limits at all. So that is also not very helpful. The therapist availability, but then with limits, that is something which has to be kept in mind. So they have to basically play a role of a good enough parent. So that is why it is called as limited reparenting also, because the person is going to meet the emotional needs of the client. So it is like a healthy parent to the child. So you are sometimes being little firm and there are limits, but at the same time, like the client knows that like you accept them, you care for them, you love them. So that is something which they should know. Okay, so it's like a healthy parent. Yeah. Say for example, so you will appreciate sometimes that I can see that how hard, like you are trying so hard, and I believe in you, and I trust you, and you can do it. So these you will encourage like a parent, and so and also reassure that there is nothing wrong with you, and I look forward to your having sessions with you, and so it's like conveying that you care for the person. And it's like that when they are feeling upset and all, you understand, you are there with their distress. So that is also very important, like a parent. So that is what it means. So basically the limited reparenting or the therapeutic relationship should offer a corrective emotional experience within the boundaries of the therapy. So that is the limited reparenting. And the therapist demonstrates the healthy adult mode. Okay, so whenever the client is using the avoidant coping modes or overcompensation, you are actually making the client understand what exactly is happening and know how to better manage this particular situation. So they are demonstrating basically how to handle the situations. You can give advices, you can give directions, and you can problem solve sometimes. You can suggest them that you can do these things, and basically in the benefit of the client. That is important. So limit setting happens. Yeah, so from the beginning, like how you are being supportive, you also set certain limits. That certain things can be done in a very stepwise manner. Certain things like you'll have to be little firm also. When it comes to violence or suicide and all that, there are very very firm limits. But other things can be little flexible. You can go gradually. So in extreme cases, when the client is not able to follow any of your directions at all, and in that case, you'll have to basically stop the therapy. The things are not working out. The substance use is continuing. Destructive behaviors are continuing. Then you'll have to stop the therapy because you cannot continue the schema therapy in that case. Okay. Yeah. So maybe like something like this can be told to the clients. I have explained to you that I don't want you to be so rude. Like they can be rude in the therapy sessions, they can be challenging, they can be demanding in the therapy. So you can give them the feedback that that I don't want you to be behaving like this, and unless you stop this, like we will not be able to progress, or I want you to apologize. You can ask, you can tell them directly, these things also. So empathic confrontation basically happens when it's like giving a honest feedback as to what exactly they're doing and how it is not basically helpful for them. Okay, so then you will confront them. Okay, so you empathize, but at the same time you also point out that something is not helping them. Okay. So you identify the interfering behaviors, confront in a friendly way. That you want to do this, but then the behavior that you are doing or the kind of the coping methods that you are using, they are not helpful, and it is not being helpful to you at all. So what do you want to do with this? Okay, you say that these are the things that you want, but then okay, so identify the emotions, the behavioral patterns, and the modes, and you will give them the feedback on what exactly is happening and why is it happening, and how that you genuinely feel that This is not going to help. Sometimes you will have to confront the kind of the coping methods that or the coping modes that come into the picture also. You will confront the mode. You will talk to the mode. Okay. So you are coming in the way of this particular vulnerable child, like you are not allowing her to feel, what she is supposed to be feeling. So you will confront, those modes also. So you will also provide the healthier alternatives. So you can do it in various ways. Like one, you can give the feedback. It can happen as a part of a chair work. It can happen as a part of the role play. It can happen. So you can give this feedback in different ways. Yeah. So like say for example, the dominating part, that is the mode of you, makes it difficult for me to be there for you and care for you the way that you need. Okay. So when you criticize me in that way, it is hard for me to be there for you. So when you start criticizing me, I start becoming anxious and then I am not able to support you. Okay. Every time that you challenge me, this is what happens, and I become little anxious and irritable, and then I will not be able to support you. Like you are confronting what exactly the behavioral patterns basically that is shown in the sessions. So some of the challenges that the therapist can face in the therapeutic relationship. One is mostly the therapists who are shifting from CBT to the schema therapy. The main challenge that they find is that they remain cognitive. They shift to the cognitive mode and they just want to look at the beliefs and the distortions, and they just quickly shift because that is the practice. It is habit, that you are comfortable with the CBT. So that is why you may shift to the cognitive aspects. Okay. Instead of eliciting the emotions or focusing on the emotions or modes, you will quickly slip into this cognitive restructuring mode. Okay. And many therapists also find it difficult to start the experiential task. They keep postponing, like they are not confident. No, I will start next time. But then the cognitive work only will keep happening and the experiential work doesn't happen because they feel they are not confident of starting the experiential methods. Not able to provide the emotional support. Like when the client is becoming emotional in the session, as a cognitive therapist, you maintain the distance. You will not show a lot of emotions there. Okay. You will not say like, I think one of the limitations of the Indian therapists is also that we don't use a lot of emotional terms also in the therapy. So that is another block that we have. So we remain silent, we remain distant, we don't say too many things. So that is another challenge. So limited reparenting doesn't happen. There you will have to be little more dramatic, and then you will have to use a lot of words like to support them, which may not be happening. Inability to formulate using the schema mode model, that may be one of the other challenges. Not being flexible in accommodating the immediate needs, including sometimes like they may require medication when necessary and all that, you have to be like accommodating all these things. Moving to the next stages, like once the initial bonding and stabilization happens, then like you will have to look at the modes, schema modes, and then to be able to visualize the healthy adult, that whether they are able to place that healthy adult and the characteristics of the healthy adult, think like a healthy adult, whether, see, initially the healthy adult mode will be underdeveloped. It's a small circle I showed you, in the mode model also you can see that the modes are bigger and healthy adult mode is smaller, in the sense that most often the other modes are operating, healthy adult mode is not operating. It's very minimal, or once in a while healthy adult mode comes in. So now, like when we are doing the mode work, we will identify that and we will write down the characteristic of the healthy adult mode, how it feels, how the mode thinks, and what the mode does, and all that. Similarly, all other modes also. Okay. Have compassion for the vulnerable child mode, awareness of why. Okay, so awareness of these critic modes and the coping modes and why they are maladaptive. So these things that it's a preparation for moving into the the next addressing the modes. Okay. So the therapeutic relationship for the schema change. So what we will do is we will point out the schemas that are triggered in the sessions, ask for the triggers, emotions and the cognition, and test the validity of the reaction, like that whether it is accurate. It's like a cognitive restructuring, like whether the schema is accurate or it is driven by the certain kinds of modes and the past experiences and all those things. And we link this to the situations that are outside of the sessions, like whatever the schemas are getting triggered in the session, that is linked to the outside situations. Okay. So whenever it is required, the therapist can use self-disclosure, and also like that to be in tune with the schemas and the modes of the client is very important. Be aware of the client coping modes, and you will have to look at bypassing the coping modes and addressing the vulnerable child modes or the parent modes. Because often what happens is that the coping modes cover the vulnerable child. I don't know whether I'm making sense, but what basically happens is that when you are using the detached protector mode or detached self-soother mode and all that, you are blocking the vulnerable child modes. Vulnerable child mode is activated, but then you will cover it with the coping mode. Okay, so that it does not exist and it is not addressed at all. So you will have to bypass this coping mode and you will have to address the vulnerable child. So can you see that this particular excessive sleeping or eating and all that is covering up this vulnerable child? Okay, or this is like in response to say overcompensation modes are coming up, and it is in response to the parent mode, maybe critical parent, and then you overcompensate something like that you are doing. So it is not allowing you to process that critical parent mode. So you'll have to bypass it and then address I want you to sit this side and I want to address this child. Okay, I want to talk to this vulnerable child and I don't want you to be there now. You sit aside, something like that. Because you are blocking and you are not allowing this person to actually access and process it. Okay, so you'll have to bypass that in the therapy. So you can do it in the chair work. Basically, we do it using the chair work. How physically place these modes on the chairs and then move this mode. And sometimes you may want to move it outside of the room, like your parent mode is now I'm placing it outside. Okay, your avoidant coping mode or detached protector, I'm just placing it here. Now I want to talk to this vulnerable child, what it feels and so you will directly you have to bypass that and then you will have to address the. Okay, so what happens in the session when you are looking at the schema change, that is focus on the specific episodes of distress, tune into the emotional response, uncover underlying schemas and the needs, summarize and check your understanding. You will check now, this is what I'm understanding and this is the schema of abandonment, rejection, whatever. That is something which is getting activated here, and is it correct? Okay. And then your work will start, or once you identify the mode, then your work will start. Okay. So maybe that you will do the imagery rescripting there, and sometimes you will also use what is called as transitional objects. You want the therapist or that stable person to be there with them, so you can use transitional objects. You can use toys, you can use the notes, you can whatever, that you can give something to them which makes them feel that the therapist is there with you. Okay. So I have just given some examples, like how do you meet the unmet emotional needs. For emotional deprivation schema, that you will have to convey that I care about you and this is the space where we can talk about anything, you can talk to me anything and I don't actually judge or mind you sharing anything with me. And defectiveness, I really think you are a good person, you are fine the way you are. So these are things which have to be told clearly to them. You should not hesitate to tell them these things. For addressing the mistress, I can guarantee you that I won't intentionally hurt you or mess mess around you, or I will make this a safe place for you. So you will have to communicate these things to them. So similarly, I have given the examples. For abandoned child, what are things that you will have to know? So yeah. So the therapist role during the imagery, what happens during the imagery and what is the therapist role? How much time I have now? 10 minutes? Is it? Then I'll wind up in 5 minutes. Yeah. So in the initial phase, it is to identify schemas and connecting the present schemas to the past and all that. And in the rescripting phase, what happens is that mainly you will have to focus on taking the blame away from the client and attributing to the situation, to the people, to the context, to the age. That is what has to happen. The child may be blaming herself for whatever has happened in the past. Okay, so you will have to definitely take away that blame. That is something which has to, like, you are not wrong here and it is not your responsibility. You will have to say this in the imagery. During the imagery, you will have to say that can you see that this is such a helpless and such a nice girl, and no, she did not know anything and she did not think. No, you are basically removing the guilt and the responsibility part from the child who is thinking that she is responsible. Okay? And processing of the emotions in terms of bodily sensations, feelings, and behaviors, and all that. So in the chair work, like I said, you can have 2 chairs or 2 or more chairs, like you will have for the modes. Sometimes, you can have for people also, like that you are punitive parent and the vulnerable child, or the detached protector and the vulnerable child. So you will have different chairs for chair work. And in the role plays, actually you can, like, the therapist can take on the role of a healthy adult and demonstrate, and role reversal can happen, and those things also can happen. And role switching can happen, like the client herself or himself is playing the parent role and the child role, and then see that whether they get a different perspective when they are playing the parent. They can, or they may not also. But no, you can use that to get a different perspective sometimes, or for cognitive restructuring also. Yeah, so the healthy adult is initially underdeveloped, but then it is strengthened over the time, and then you will strengthen the behaviors that are a part of the healthy adult, coping that is a part of the healthy adult. Okay. So typically the structure of the session would be the first third of the session is attunement phase, that you are connecting emotionally, and then you are that identifying triggers and all that, and then you will work around that modes that are triggered. And in the final phase, you will summarize, and you will know that you will make them feel better at the end. That is very important. Every session, the client should feel better. That is very important. Okay, so you may end with a neutral situation, or whatever safe place that you have identified. You can use that in the session. So therapy schemas getting triggered in the session, that is something the therapist should be careful, and they should identify, and that should be discussed in the supervision sessions. Culture plays a very important role in terms of, like, what is subjugation, what is self-sacrifice, what is not self-sacrifice, what is dependence, what is not dependence, what is like problematic dependence, when and how do we define that. Those things are like little different from the Western cultures. So that is something which needs to be kept in mind when we are doing this. And because these therapies are not culturally adapted, we have to do that. Okay. And sometimes, like the therapist taking a very active role and punishing the parent in the imagery, which may not be acceptable to the client. Whatever is parent is a parent, and we have to respect, something like that. Okay. So those things needs to be kept in mind, like and sometimes they may not be comfortable, just the therapist entering and doing something in my life, they may not be very comfortable with that. They may want somebody else to be there in the imagery. I want my mother to be there in the imagery, not the therapist. So it should be okay, that you can allow the mother to be there or somebody else to be there, and not you as a person. Because generally we enter the imagery and soothe the child, all that we do, but then, like, if they are not comfortable, it is better that we use other people also. Yeah, so how do we separate the enmeshment and it becomes very difficult to see what is dependence, what is enmeshment, what is not enmeshment in a collectivistic culture like this, and how much of emotional inhibition is a part of culture, like how expressive they are and how expressive as therapists we are. That is also influenced by the culture, and yeah, rescripting or chair work, like what are the things that will impact these things, that is something which we have to identify in our cultural background. That is, I don't think we have reached that far, like to identify all these nuances. So last phase is that like they have to develop autonomy and responsibility, and then we are moving towards the termination. Know that we want the healthy adult part to be playing a role and take over. No, so that is what has to happen. And they should be able to identify the modes in different situations and problematic situations, and they should be able to identify the modes, and they should be able to use the healthy adult mode. So that is when you will decide that now the therapy can be terminated. So some of the tips that can be kept in mind is the therapist should be able to identify which mode is in the room. You have to identify in the session what mode is playing a role now. Okay, and that is like you can easily identify that. Once you are aware of the modes, then you know that, like, based on what the client is reporting, how the client is feeling, and know that you will easily identify these modes, and start the experiential techniques as early as possible. Maybe second session, third session. Don't wait for lot of sessions. Okay. Generally 15 to 30 minutes of experiential work in the sessions, and then you will summarize and conclude the sessions. Behavioral pattern breaking happens like towards the later part of the therapy, and here, like that you will have to look at motivating the client to use different methods which are much more healthier than these maladaptive modes. Strengthen healthy adult functioning over time. That is how it happens, and you will have to go back to the conceptualization whenever there is confusion in terms of the modes or in terms of the coping modes and all that. Okay, so the therapist's readiness and willingness to take a parental nurturant role is something which is very important, and to be expressive is something which is very important, and also to look at unresolved traumas of the therapist and the maladaptive schemas as well as the modes. Another important hurdle in assessment is the lengthy questionnaires. Like most of the questionnaires that we have for schema therapy are lengthy, whether it is your the early maladaptive schemas or schema mode inventory, all those are very lengthy. So that is one of the difficulties, and a lot of terms may not be easy to understand. Okay. And cultural adaptation of using terminologies, because they use a lot of terms, and our clients may not be so sophisticated, or it is not that we don't use so much of language to express emotions. So that may be one of the limitations. That is something which we have to keep in mind. Also, we have to simplify things. Yeah, so with this I'll stop here, and I think now the Priya will take over and elaborate. Yeah.
You can put up the slides.
You need to see there. Because people might have question and answers.
That is later.
And also comment.
Yes.
Thank you so much, Dr. Manjula. It was such a delight listening to ma'am. Um, so, as you know, we've sort of understood what schema therapy is and how important the therapist is for schema therapy. I will go over the applications and challenges that we experience while doing limited reparenting. So, ma'am has emphasized enough on how the therapist plays such an important role, how the therapist needs to be attuned to the client, right? Like she was talking about how it is very investing for the therapist. It is not like we are, merely present and just facilitating the process. We are very proactive in the whole process. Like for example, when we are, let's say, doing imagery rescripting, we are entering the image, we are taking a very proactive stance. So now this whole approach of the therapist requiring to be, let's say, available outside of the therapy sessions, or the requirement for the therapist to be so attuned to observe the non-verbal things in the client, or to maybe confront when required, or to provide care when required, or to give very empathic statements when required, can can be sometimes having its own challenges. So I'll go over that. Now, when we talk about limited reparenting, as we understood from ma'am's presentation, that it is an inbuilt part in the process of schema therapy itself. So it can be considered to be, the heart of schema therapy. It lies in the center. Whatever we do in schema therapy, whether it is giving them the formulation, or whether we are doing imagery work, or we are doing chair work, or we are maybe doing some other techniques in the client, limited reparenting remains in the center. But we are constantly the attuned, good enough parent. Okay, so it is a technique and it is a process, and it creates a model for secure attachment. Now, one thing that we need to remember when we're doing schema therapy is that schema therapy is attachment informed. It is heavily built upon attachment. It really draws upon the developmental trajectory of the client, which is why we take the life history, taking their history, connecting the dots. Like ma'am said, that if the client is not willing to share their life details with us, then that becomes a hindrance. We can't really go beyond a certain point if the client is not wanting to share much with us. So it is attachment informed, and limited reparenting helps in creating the model of a secure attachment. Because the client did not receive secure attachment, which is why all the modes were formed, which is why all the schemas were formed. And now we want them to have one model of a secure relationship in their life. So it has to be done skillfully. Let's break down the term itself. It is not parenting. It is not reparenting. It is limited reparenting. So there has to be a balance between limits and reparenting. So it's very useful. We've understood, very useful with clients with unmet emotional needs and who are still childlike, like people with childhood trauma or people with cluster B. And it's not just about being empathic and caring. Okay, it's let's imagine a dimension. On one hand of the dimension of limited reparenting, there are the softer skills, nurturance, care, guidance. But is parenting only about being nurturing and being caring? Parenting is also about setting limits, right? As maybe some of your parents or some of you might be having nephews or nieces or other children around you. And parenting is not just about being that warm, sweet, caring person. Parenting is also about telling what is not okay, right? Parenting is also about being assertive. Parenting is also about saying that this is not acceptable, all right? So it is not just about being empathic and caring, it's about setting reasonable limits and gently highlighting maladaptive patterns as well. So there are four core
aspects of limited reparenting: care, guidance and direction, empathic confrontation, and lastly, limit setting. So, on the dimension, as we move from being softer to being more assertive, this is how we move. And we can club guidance and care into one single aspect of providing care and support. So, what do we do? Let's talk about the applications of it, and then I will simultaneously cover the challenges and what do we do about those challenges. So, we are attuned to the client, right? When we are providing guidance and support, we are attuned. So, that means we are not just listening to them through our ears, we are also observing the non-verbal, जो उन्होंने नहीं कहा, what they have not said. Let's say they are talking very fast, but usually they talk a little softly. So we may say that, hey, I feel that you are a little anxious. Is there something that is bothering you? So we are showing care by means of doing that. Okay, or sometimes if they are, let's say, appearing to be very tired, we are attuned. Sometimes I tell my clients, you look a little tired today. Are you all right? Did you sleep well? So that is I'm being attuned to them, right? I'm noticing what they have not told me. Being empathic and validating. Now, some of you will think that in all kinds of therapies, we are being empathic and validating, aren't we? It's not like this is something unique to schema therapy. But what makes it unique is that we go a little beyond that. We make sure that we know that we are being validating. So we are not just going to say that I understand this is difficult. And when we add one or two more sentences, of course, it can be challenging when life throws these kind of curveballs at us. It can be very difficult. And you are somebody who has always been very, let's say, motivated, and naturally, with the kind of experiences you're going through, it is understandable that you are feeling quite low and less energetic, right? So we are not just saying that, hey, I understand this is difficult. We are making sure that we are showing that we trust them, we believe in them. So being available outside office hours, I'll not go much into this because this ma'am has already highlighted. Guiding in their essential life decisions, expressing genuine concern. There's a lot to do with genuineness, okay? So we'll not just say things like, yes, this is difficult, etc. We have to be genuine with them. Okay, genuine concern that, hey, I hear that you really want to be with this person, but from also what you're sharing with me, it sounds like the relationship has got its own challenges. And maybe we could reflect on what does this relationship bring for you. So if I'm concerned about my client, maybe my client is trauma bonded with their partner and they are not able to see a lot of things, but I am able to see because I am at the other side. So I can express that concern. I can take that liberty as a therapist, as an empathic therapist, to express that genuine concern for the client. And we can also appreciate the client, communicate that they matter. Because see, sometimes they, owing to their difficult relationships in the childhood, they may have difficulty in trusting us. So we have to gain that trust. We have to communicate to them that they matter. Okay, like we can express happiness. I was really looking forward to our session, or we can show that we remember some important thing that they have shared with us. So what is the utility? It helps in meeting the unmet needs. So this care dimension, the care and support dimension, what is it useful for? Helps in meeting the unmet needs of clients who are still childlike. It helps them feel seen, safe. It is useful in, like ma'am said, schema healing, certain schemas, fosters a feeling of secure attachment, creates a role model of attuned, healthy, good enough parent. But there are challenges of this particular phase or stage of limited reparenting. What are the challenges? Client can become codependent on us, right? That now for every decision, they cannot proceed with the decision unless they have taken a session. So they can end up becoming codependent on us if nurturance is not balanced with healthy limits. We don't just have to be that safe, nurturing parent. We also have to be somebody who encourages them to become autonomous. Or the therapist may also experience burnout. That I have shared my number with the client and now the client is, let's say, taking the liberty to call me at 2 o'clock in the night, right? So it has to be balanced. The therapist can experience burnout if this is not done carefully, or the therapist can have negative countertransference, right? Let's say the client is sending long messages, long emails. Every 2 days, there is one long email from the client. Or clients who have entitlement or superiority schemas can expect too much out of the therapist. The clients who have criticality can become critical towards the therapist. So these are the challenges. Or let's say the therapist themselves has a self-sacrifice schema, themselves has a subjugation schema. So the therapist may feel that they need to go out of the way to provide care and nurturance. So what do we do to manage these type of challenges that come with the care and support aspect of limited reparenting? We will provide care and nurturance, but at the same time, we are going to be mindful of how much is too much. Am I getting depleted? Am I having to work too much outside of my working hours? Is it affecting me emotionally, or am I experiencing something? So there comes dual awareness. We don't just have to be attuned to them. We need to be attuned to ourselves as well, right? We need to be mindful of our own emotional states. Setting limits using empathic confrontation, I'll come to that. Using empathic confrontation as and when needed. We, of course, don't want the client, we neither want them to be codependent on us, nor do we want them to, let's say, we don't want to feel exploited, right? So empathic confrontation is also required if we are seeing that some limits are being crossed. We need to prioritize our self-care. We need to prioritize own boundaries. So, for example, during the COVID times, I was down with COVID, and one of my clients, back then I was like really new into schema therapy, and one of my clients had a tendency to like be very dependent upon therapy sessions, and I had severe symptoms of COVID, so I had to take a 2 weeks long break. But the client was very uncomfortable with me prioritizing my health, and she said that at least one session you can take in a week. At least see me, right? And I think I was a little bit on my self-sacrifice schema, and I did end up meeting the client only to end up feeling quite frustrated that why did I have to do that? I have cancelled everybody's session. Why did I have to? So that is where supervision kicks in, right? That is where our own therapy, being attuned to our own selves, prioritizing our own self kicks in. So this is where that whole balance aspect comes in. So we have to be genuine and open with the client. If the therapist is unable to, if I'm unable to meet a request, if they say that, no, you have to meet me at 9 o'clock at night, and I tell them that this is my family time, it is not possible for me to accommodate a session at that time, but they keep requesting, I have to be genuine. I have to tell them that, hey, look, while I understand that that is a time that works for you, but this is not something that would work for me. So we have to be open if I'm not able to meet a request. And we have to remember that it is limited reparenting. The word limited, I think, really stands out every time. Now, what is empathic confrontation? So the therapeutic relationship is not just about a safe haven. No, it's not just about feeling happy, safe. It's about growth. How will the schemas heal if it is going to be repeated every time? So it's meant to be a source of change as well, right? And change and growth are not very painless, isn't it? It is a little painful to undergo growth, to undergo change. So, firstly, before doing empathic confrontation, we have to be mindful of our own feelings and schema activation. That is it something to do with me, or is it really the client's maladaptive pattern that has to now be confronted empathically or highlighted, right? Is it maybe something that needs work inside here, or is it something that needs work outside there? So we have to be mindful of our own feelings and schema activation. And the confrontation. See, again, I really like how Jeffrey Young has coined the terms, right? He says empathic confrontation. So it is such a blended thing, right? Where we're talking about confronting, but in an empathic way. So the idea is not to challenge the client or to put them down. The idea is to very gently, empathically, lovingly bring up that concern, right? That this is something which I notice,
and I'm concerned that this can be a little damaging because of so and so reasons. Okay, so we express it in a very concerned manner. We don't want their shame to kick in, because the moment shame kicks in, the moment their inner critic, their punitive side gets activated, it's over. It's going to lead to a dropout, because they are going to feel judged. But the idea is not to make them feel judged. It is coming from a place of concern. Like if my child is to do something which is not okay, and if I yell at the child, the frontal lobe is going to shut down, right? But if I say that, hey, I know you were very angry with your friend and that is why you hate, but you know what, beta, this is not a very appropriate thing to do. Maybe we can, do it in some other way. You could have called ma'am and ma'am could have maybe intervened. So the idea is to gently highlight that, hey, look, this behavior is not great, but I understand where this came from. That is empathic confrontation. So it's about rejecting the dysfunctional behavior, not about rejecting the client. I'm not rejecting you. I'm rejecting this behavior, and you are not your behavior. Your behavior is separate. And again, we link it to their childhood, right? And unless that link is established, bullying will not happen, because they are not doing it deliberately. It has become a pattern. So by saying that you should not talk to somebody like this, I'm not doing a great favor to them. They already know that they shouldn't be doing this. So why are they doing this? What is happening? The schema has to be brought up, highlighted, then chair work, imagery, everything else follows. So I've taken a sample dialogue of empathic confrontation from Dr. Anudan's book, Schema Therapy for Borderline Personality Disorder. Why I took this and why not something of my own is because I think it is so crisp over here, and you will see as I go through this. So the therapist is talking to a client called Nora, and the therapist is saying, Nora, I noticed that you are asking me to support you in the way you behaved last week towards your son's teacher. But I get the feeling that you want to force me into supporting you, and that you will not allow me to have an opinion that differs from yours. This is very annoying for me. See how the therapist is being genuine. This is very annoying for me. It makes me not say what I'm really thinking. Again, the therapist is being genuine. But at the same time, I know when I do that, I'm not helping you. I'm concerned, right? So I'm being genuine, but I'm also concerned because I want to help you. So Nora says, oh, great. Nora is angry. Oh, great. So you think I dealt with the teacher wrong too? Now you also think that I'm an idiot, right? So Nora's critic is getting activated. No, that's not what I'm trying to tell you. I meant that because of the manner in which you try to force me into agreeing with your point of view, I don't dare share my real opinions with you. This would create a distance, right? Again, empathy. I want to be close to you, but this would create a distance between us. And if it continues, I don't want that to happen. I'm concerned, right? I want to be there for you. And after a short silence, the patient is sad and they say, maybe I don't want that, but I feel you're working out of me too. Abandonment schema getting activated. Yes, I understand that. And I think what is happening between us now is something which happens when people don't agree with you. So I'm highlighting a pattern. It's not about me, it's about your pattern, Nora. I want you to be aware of that. You become very defensive and feel rejected, and before you know it, you are right in the middle of your punitive mood, right? So the therapist is again highlighting what is happening. And you think that everyone, so now you're formulating this behavior. Now you think that everyone who doesn't agree with you thinks that you're an idiot. Again, formulating, highlighting how the critic is getting activated and rejects you. I do understand your reaction though. Nora, I am your therapist. I understand why you behave that way. In the past, you were never allowed to have your opinion with your mother. Your mother would make you out to be a fool when you said anything. But you have to realize that you are in a different situation now. Can you see how empathy and confrontation are being balanced? I don't think you're stupid or fool, so I'm not judging you. I think that sometimes you deal with things well and other times not so well. I want to be able to tell you this without feeling forced into agreeing with you and everything. So I would like to ask you to not isolate yourself and shut me out, but to try and discuss the matter in a calm and relaxed way. See how beautifully empathy and confrontation have been balanced, right? Such a beautiful blend.
So what is the utility? It helps in highlighting dysfunctional behaviors and patterns in the client. It helps them be accountable, right? We want them to be healthy adults. We want that healthy adult to grow. And accountability is a healthy adult function. It helps the client learn that rejecting dysfunctional behavior is not equivalent to rejecting me. So if I tell my child, hey, this was not great that you went and hit your friend, I am rejecting the behavior. I am not rejecting the child. So it fosters secure attachment, and I'm utilizing negative counter transference meaningfully. I'm not sitting with that negative counter transference, so I'm feeling angry with the client. I'm utilizing it. I'm bringing it up in the session and encourages healthy adult behavior. What are the challenges? Client can become defensive, isn't it? Here also we saw Noora was becoming defensive. Yes, sir. Yes, sir. Please just give me like 3 minutes. Yes. Therapists can also become too empathic, too confrontative. Therapists might be anxious, like ma'am said. There can be anxiety, right? We can feel anxious. And help let the dysfunctional behavior slide. There's a risk of losing clients to drop out. So how do we manage? We become mindful of our own schema activation. We allow ourselves to do the empathic confrontation from a healthy adult part, not from a vulnerable child or critic part. We have to be in supervision and therapy, and we have to be reflective whether client is ready for empathic confrontation. Quickly going through limit setting. So it's also about to teach limits, to keep the therapist and the client safe. If the behavior is severely hindering therapy, like ma'am pointed out, too much contact outside session, misbehaving, we want to be safe, right? And we want them to be safe too. Substance use, unrealistic expectations. And skip the example. Utility to keep the client and therapist safe, help the client take accountability, encouraging healthy adult behavior. It builds frustration tolerance. They also need to know what's not okay, creating healthy boundaries. Challenges, similar challenges, client can become defensive, they may feel abandoned. Therapist may be scared of offending the client. Therapist may rationalize their behavior too much, rationalizing may happen in the therapist's head. Therapist schema activation preventing them from doing so, or the therapist might do it in a punitive way. How do we do it? Similar things, being mindful of our schema activation, assessing whether limits in this situation really need to be said, or can we just do empathic confrontation. Again, being consistent becomes very important. So to conclude, let's remember that in limited reparenting, balance is the key. We need to know how much is too much, how limited is too limited. We need to take care of ourselves and our needs also while meeting the unmet needs of the client. Thank you so much. Thank you so much. Okay.
Just feel that both the presentation has been elaborated and very comprehensive. Pity on the audience. I was helplessly watching them very comfortable. I don't know what to do. You are here to listen to and learn something out of whatever is being done. So much pain has been taken. We are traveling all the way from demands to Delhi. Anyway, I don't know whether I can offer any questions from the audience.
I think that things are getting delayed also.
Yes.
Yeah, I think that their categories is clearly not there. I don't know why. I don't know. That is happening within a conference that I'm not sure.
Anyway, thanks to both the presenters for giving us so much of material on schema therapy and limited reparenting. I cannot say anything more than this.
Thank you so much.
There are very few people.
Very few people, yes.
There is a gradation.
और इनके साथ ही दूसरी स्पीकर भी इनकी करनी है। Good afternoon, everyone. We are starting with the workshop on the topic Working with the Body Mind Principle and Essential Skills. I would like to welcome Dr. Sudipta Roy as a chairperson for this workshop, and I would request Dr. Bhavna Mukund to please felicitate her. Dr. Sudipta Roy is a director at Silence Center Surat, adjunct professor, PPSU Zonal VP, CPSI, VP Psychodermatology Association of India, President, CMMHF, General Secretary, and she has a professional background of MA, MPhil, PhD, and 31 years of experience. Her area of interest are child and adolescent mental health, neurodivergent psychodiagnostic assessment, and psychodermatology. Now, I would like to invite our next chairperson, Dr. Preeti Pandey, on the stage, and I would request Dr. Bhavna ma'am to please felicitate her. She is a clinical psychologist with her area of interest in PTSD, complex trauma, and obsessive compulsive disorder, with a particular focus on women who have experienced abuse and relational trauma. Now, I would like to invite upon our speaker on the stage, Dr. Sukanya Rai. She's an assistant professor at Mumbai campus, Center for Human Ecology, School of Human Ecology, Tata Institute of Social Sciences. I would like Dr. Sudipta Roy to please felicitate her. Now I would like to invite Dr. Priya Puri on the stage and request Dr. Sudipta Rai to please felicitate her. Dr. Priya Puri is a clinical psychologist and entrepreneur, certified trauma specialist providing holistic healing, expert in trauma-informed care and schema therapy, founder and chief clinical psychologist at the Healing Space. Her professional background includes MPhil in clinical psychology, PhD in clinical psychology in MANS. Now we can begin with the workshop.
Hi everyone, good afternoon, almost evening, and welcome to the workshop on working with the body mind. First of all, I think on behalf of both Priya and myself, I want to thank CPSI, the organizing committee, for allowing us to present this workshop because this is not an often talked about topic when it comes to clinical psychology. Working with the body often is relegated to the zone of, non-evidence based work or really not therapy as such, and there's a lot of misconception around that. So I think this is a very special experience for both Priya and me to be able to speak to you all and also maybe share some of our knowledge and experience as we go through this. All right, so these are some of the objectives of what we are going to cover. We'll try and cover most of it today. So the first one is to understand the importance of the body as a storehouse of implicit memories. As a trauma therapist, when we work with complex trauma and dissociation, a lot of processing brings the client and the therapist back to the body. So it's important to understand the importance of that, and the first part is going to cover that. Then we hope to be able to transfer some of our knowledge about the principles and techniques to assess these psychosomatic associations and develop skills to facilitate body awareness in clients. And to gain, the time that we have, this is very short time, and body psychotherapy again is a very, very vast field. So I think we might just be able to name, not even give you an overview, but just name some of the body-based psychotherapies that are there, which allow us to work with the nervous system directly. I want to introduce this statement to you and I want to see what's coming up for you as you read this. Of course, as students of psychology, we are aware of the conscious and the unconscious, and we understand the importance of the unconscious, but the unconscious is the body, as Eugene Gendlin says. So, what is this bringing up for us? Would anyone like to share what is this bringing up for you? Hmm. Right. Right. So let me come down here. I like to move a little bit. I have a slide changer, so maybe we can, while I'm talking to you, we can set that up. Yeah, so we are saying that the unconscious gets activated somehow. Uh, but why are we saying it's in the body? You know, we are saying the unconscious is the body. So um, just tell me, what is this bringing up for you? Do you like this statement? Do you not like this statement? Yeah. Mm-hmm. Hmm. So the felt sense is in the body is what's coming up. Any other views? Anything that's coming up? Hmm. Body remembers the reaction. Hmm. 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 So we are saying the reaction comes first and it comes in the body. Yeah, 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 yeah. Yes, yes, yes. So we are saying that but the reaction is very body based, is what we are saying. Yeah. Okay. We feel it in the body, like she said that the felt sense is also there. Okay. So let's see what this brings up for you. Experience shapes the brain or the self. This is a known statement, and I think we have understood this when we talk about um, how the brain gets memory stored, etc. So this is a familiar word, right? But what is important here is to notice the word experience. And I want to ask the audience here, how often do you find yourself using the word experience in psychotherapy? How often do you use it? Very frequently? Yeah. What comes up when you say experience to the client? We're very used to saying what do you think, what do you feel. But when you say experience, does something different come up? What comes up? Mhm. Sometimes an I don't know comes up. Okay. Anything else? Hmm. Mostly negative. Okay. So let's pause a bit and think that experience we understand as something. It connotes something for us. But when we say experience, what does it mean for the person? What does it mean for the client? Have you ever noticed it? Hmm. 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 The experience. It really kind of helps people land into something. It's a very landing word. Ah, like you're feeling it again right now. You're experiencing it. So it's a present moment. It's a very present moment thing because when you say experience, people usually associate it with the present moment experience. So they feel it in the body. And also, like you were saying that for us, experience might mean the whole gamut of thought, feeling, behavior, everything. But when we use the word experience in therapy, we directly touch base with that present moment. What is it now? Or what did you experience in the body? Now, okay, great, it's working. So, we know this, but this is something that sometimes we have to also work with our clients, because sometimes we notice that some clients are very much in the head. Now, I just want to hear from you, are there any signs that tell you that your clients are going to the head more often, that they have difficulty landing in the body? Are there any cues that you get from people? Anything that you've noticed? They become very verbal, okay? And what else? Hmm. That has a disparity. Yeah, exactly. Yeah, so that's one thing that they say they feel, but what they're communicating is what they think. And any other cues that tell you that they are not really in the body, they're, sort of in the mind, anything that you see in their body language that tells you that they are really going up there and not really landing in the body? Okay. So you feel that they're not there. They're kind of zoned out a little. Yeah. A very common sign, which you will probably notice a lot with these thinking clients, or sometimes we call that some clients have a very active thinking part of them. You'll notice that when you ask them this question, what are you experiencing? They'll go, do you notice what's happening? So the orientation is upwards. Yeah. And so what do you do then? Is there something that you do to help them come down to the body? Hmm. So they'll again sort of go, hmm. And even if they close their eyes, you know that they're kind of oriented upwards because the chin is up. Yeah? Chin is up, or like that the eyes are still up there. So, one very quick way to do this, and we're going to do this right now, is to say, and body based psychotherapy is very gentle. The language is extremely invitational. So, we go something like, I wonder if it might be okay for you to close your eyes or look down towards your knees so that you can reduce the amount of visual stimulation. We take in a lot of the world through our visual senses. So the visual senses are the most practiced senses. But which are the sensations that are the most primitive? Which are the ones that we are born with? Touch and sound. Right? So it's very easy for us to zone out if you're still taking in the world with the most practiced senses. So it helps to sort of invite them to that let's see if we can just close our eyes, or if that feels uncomfortable, see if you can look down towards your knees. So that's going to cut down the visual stimulation. And exactly what we're trying to say, see if you can go inwards. Sometimes people wouldn't understand, and also they might deflect if there's a lot of trauma stored inwards. So what might help is to say, just look downwards towards your knees. Then you know that they're not looking at you or not feeling that pressure to look at the screen if you're doing online work. So that might reduce that stimulation. So therefore, for us to be able to comprehend body psychotherapy, these are some points for us to understand that when we are dealing with body psychotherapy, we are dealing with experience. We are not dealing with just thoughts or just emotions. And we'll come to all of that, how we slice it up. But experience includes body and mind. It emerges as a life process in the subject environment relationship. Experiencing the world and experience oneself is grounded in the experiencing body. So, like all of us said, that when you experience, you're very much in your body. You can't think what you're experiencing. To actually sense what you're experiencing, you need to go into your body. And if you find that the client is, I think I feel, or I think this is there, then you still know that the thinking part is active. Body psychotherapy is more in line with the paradigm of the embodied mind, and we will talk about what is the embodied mind than other psychotherapeutic approaches. The more a person, and this is very, very important for body psychotherapy, the more a person can experience themselves, forgive the gender, the more regulate their needs and emotions and their relationship to others. Therapy is a lot about teaching clients to regulate their nervous systems on their own, because I think in Priya's the workshop that was just preceding this, she spoke of how if the client is increasingly reliant on the therapist, then that fosters codependence. So after a certain point, you're scaffolding. So after a certain point, they need to take off. They need to be able to rely on their nervous systems. So that is what we're talking about here, that the more they learn to experience themselves. What is the themself here? It's actually their nervous system. The more they will be able to self-regulate. Positioning body psychotherapy as an experiential approach jettisons biologistic thinking. So everything is about, how often we think of our own bodies as a group of cells. Do you think of your body, even a single cell, as a process? That each of your cells also has a process. It is born, it goes through a cycle, it dies off. Your whole body is an intelligent system. It's not something which is static and very biologistic. So when we look at the field of body psychotherapy, something that comes up often is the concept of implicit memory. And I think in some of the workshops so far, we've been naming this, that there is the explicit memory system and the implicit memory system. So Peter Levine's diagram in one of his books, you can see that there are two major systems. One is the explicit memory, the other is the implicit memory. For survival. Thank you. So these are the memories that are critical for survival. And because it is critical for survival, they are going to show up in every moment. Even the so-called memories you think are neutral will also be colored by these implicit associations. Now, this is extremely important for body psychotherapy, because when you're working with body psychotherapy, you are constantly working on making the implicit explicit. And that's where the trauma is. So when we are working with trauma-based or trauma-focused body psychotherapies, the challenge is constantly to work with the client's awareness. We are constantly trying to bring in, and we'll talk about that, their embodied self-awareness. So let's see, this body as an implicit memory. Now we all understand the moment I say nervous system, you think about the brain and the spinal cord. But you also know that's only part of your nervous system. That's your central nervous system. A lot of your nervous system is outside your brain and your spinal cord, and that's your peripheral nervous system. Where is all your peripheral nervous system? Can you show me where your peripheral nervous system is? Huh? Where is it? Which part of the body? So it's all of your body, your limbs, your organs, everything. Your peripheral nervous system innervates your entire body, so to say. And your peripheral nervous system is constantly doing the housekeeping functions of your body. That is why Gendlin says the body is the unconscious, or the unconscious is the body. We are not aware of what's happening minute by minute, or second by second, or nanosecond by nanosecond, because the body is, because the peripheral nervous system is at work. There's, of course, a rich set of connections between the CNS and the PNS, which is constantly exchanging information. And if you are aware, it's outside the purview of today's conversation to have a really long conversation on the polyvagal theory. But the polyvagal theory, again, is one of the basic sciences that we need to understand. It's called the science of safety. The polyvagal theory is called the science of safety. So the polyvagal theory, the gut-brain axis, and we also have this, idea that we often say it's muscle memory. It's like how you twist a bottle so that nobody can open a bottle, but you know how to open it. And then how do you know that? And you say it's muscle memory. So it's that procedural memory that we were talking about. You can't quite name what you do. So all of this tells us, or really kind of substantiates, the science behind why the body is the storehouse for implicit memory, which is why we say the body keeps the score. Or this is why we say that the different ganglia are storing different kinds of trauma memories, and that's what you're doing. You're really sort of working through the energies that are trapped in this ganglia, and you are working towards releasing all of that. Yeah? So let's go further. I'll give you a little bit of polyvagal theory because without that, it's difficult for us to really understand this. Not going into the basics of it, which is that Stephen Porges gave this theory, and being a neurophysiologist, he has really sort of done a lot of research with the vagus nerve. So the vagus nerve is the 10th cranial nerve. It's the longest nerve, which is why it's called the vagus, so which is the wandering nerve. The polyvagal theory is based on three important principles. The first principle is the hierarchy. So what is this hierarchy? If you attended Dr. Shalini Anand's workshop, she was talking about the hand model of the brain, right? So the hierarchy says that the topmost layer has a regulating influence or a control over the lowermost. So the prefrontal cortex has more control over the limbic. The limbic has some control over the reptilian part. So that's the triune brain theory. There are criticisms of triune brain theory as well. But what is important here to understand is this is called the Jacksonian hierarchy, which means that when the prefrontal cortex is in charge, anything that's coming up from the reptilian brain or the limbic system, they are going to be in control of the prefrontal cortex. But just like your MCV goes off with excess voltage. So if there's survival at stake, which means that your reptilian brain, have you ever seen reptiles having dinner together? They don't have social behaviors. Reptiles don't even nurture their youngs. Their younglings grow on their own. Right? Reptiles never have any kind of suckling behavior or anything like that for their young ones. So that's why the reptilian brain is only for eating, hunting, sleeping. Eating, hunting, sleeping. So it's a sleep-wake cycle that's happening. In only the mammals, we see that there is some kind of, mammals and birds, we see that there's some kind of taking care of the younglings. So there needs to be some attachment. So attachment comes from the limbic brain. And in the higher primates, we see that when this Jacksonian hierarchy is intact, the prefrontal cortex has a regulating influence on these three layers, on the other two layers. So what polyvagal theory also says that if there is survival at stake, that is going to really excite the lower layers, and that is going to flip this Jacksonian hierarchy, which is what Dan Siegel says in his hand model of the brain, that the lid of the brain is going to flip because the Jacksonian hierarchy has been totally flipped. The second term Stephen Porges introduces called neuroception. Neuroception is the nervous system's automatic and autonomic capacity. It's its own capacity. It's not regulated by any other any other system, so to say. We have a lot of systems: cardiac, respiratory, circulatory, blah blah blah. All of that. No other systems have an influence on this particular system, which is the neuroception. It is the most important system for survival. Why? Because its only job is to detect danger, threat and safety cues. That's its only job. Depending on the cues that are being picked up from the environment or from the internal world or from the relationships that we have, this particular system is going to then send signals to all other systems, to the cardiac, to the respiratory, digestive, every other system. So the neuroception is literally our gateway to safety. If in therapy, we can actually enhance or optimize the client's neuroception, you bring in regulation. So there's a third concept, which is co-regulation. Porges says that co-regulation is a biological imperative, which means that if the infant did not develop or did not receive co-regulation as an infant, what's going to happen? They will not have the capacity to self-regulate. So I always say this, co-regulation precedes self-regulation. It's applicable in life as much in therapy. In therapy, if co-regulation is not happening in the session, it means that the client will not be able to self-regulate. Only when you see co-regulation happening, you know that Now they are developing the capacity to be able to self-regulate. So why is this important? Because this brings us to the concept of coherence. Coherence, the word in psychology, in trauma work, in working with the nervous system, is used in very many different ways. But in the context of the polyvagal theory, the way we understand coherence is that it's the return to safety. It's the nervous system's ability to come back to safety when the danger is over. So where there is little coherence, what happens? People feel stuck on or stuck off. But coherence is the ability to sort of come back, regulate back. So coherence is the return back to self-regulation because the autonomic nervous system loses the regulation. And often the autonomic nervous system goes into hyperarousal. What are the kinds of emotions we see when people are hyperaroused? Can we name some? Anxiety and emotions, anger and any other, annoyance, any other, irritability, any other, fear. Yeah. So a lot of these fear, anger, anxiety, a lot of these emotions are about or really sort of the kind of attachment cry that we see. So that's also a kind of sympathetic arousal. And so somebody rescue me or looking for an attachment figure who can rescue them, that can also be one. Another one which we often miss is fawn or appeasing. So when flight is not possible and fight is not possible, the only way to survive is to fawn or appease the enemy, which in the extreme becomes Stockholm syndrome. Yeah. So all of that is because of the hyperarousal emotions. Now a healthy nervous system, which is not traumatized, so to say, a healthy nervous system has this ability to get back into coherence. So the ability to sort of come back to ventral vagal or come back to safety. That capacity is called coherence. With trauma, this capacity for coherence really sort of becomes limited. So the nervous system stays stuck on or stuck off. So another point, and I know that we don't have the time today, but this word okay is often used in trauma work and in body-based psychotherapies. Okay means just okay. It doesn't mean one is feeling safe or joyful or even very safe. Okay means that return to safety. Yeah. So safety might not always feel calm. Safety might not always feel joyful. Safety for Priya might be different. Safety for me might be different. So safety, again, the experience is very different and it's personalized. For example, when I work with clients who live in very turbulent zones, they have a session, during the session they feel calm. When they go back, will they feel safe while they are calm? No. Why? Because they need to be hyper vigilant in a noisy environment. That is a safer zone for them. So safety, we tend to confuse this, but safety in the polyvagal sense is not about really feeling calm, but safety is about feeling okay. Your okay and my okay might not be the same band, might not be the same brain waves. So why am I saying this? This is because we are, so trained in this concept of mind-body duality that we tend to think that the mind and the body are connected, they are, exchanging information. But in the tradition of body psychotherapies, we don't believe in mind-body duality, we believe in mind-body unity. So the mind and the body are not two different systems. They're not connected, they are interrelated. There's a difference between that. So the mind and the body are interrelated. And this is something that really challenges our thought because we think some things affect the body and some things affect the mind and then they have impact on each other. But what is impacting the body is also impacting the mind, and what is impacting the mind is also impacting the body. So unity is what we are really talking about. So therefore, in body psychotherapy, this statement becomes very important. I do not exist because I think, but because I am embodied. The more dissociation there is, the more complex trauma, you notice that people do not exist in their bodies. They are disembodied. So therefore, if you ask that golden question in trauma therapy, where do you feel this in your body? What kind of response do we get? I don't know what you mean. Why are you asking me this dumb question? So it's scary to land in the bodies. So the whole game is about self-awareness. But it's not this kind of self-awareness that we are used to. When I say self-awareness, what comes to your mind? Exactly. Being very mindful about it. Thank you so much. So mindful about our thoughts. So this way of being self-aware in body psychotherapy is called conceptual self-awareness. So this is about me being aware of my thoughts, me being aware of my, my prefrontal cortex basically. So how I think or interpret the world. So this is one kind of self-awareness. This is called conceptual self-awareness. But there is also embodied self-awareness. So that self-awareness which helps us to embody our awareness in the bodies. So let's take a moment to do that right now. So I'd like you to, I gave you the instruction right in the beginning. So go ahead and see if you can close your eyes or look downwards. And just bring your awareness to how your body is resting right now or how much it is resting right now. What does it need to rest a bit right now? Yeah, just go ahead and play with your hands, arms, legs, feet. Just play with it and see if you can make them just a little more comfortable. It may take a while to just land in your bodies, and that's okay. And as you do that, just notice what's coming up in your mind, whatever's coming up. See if you can just witness it without getting into it. Like whatever is going on is kind of like a pool, and you're sitting by the pool, you're not in the pool. So see if you can be with it, not in it. You may initially notice that you're aware of your thoughts, aware of certain worries. And then drop your awareness to your heart. If it helps, place a hand on your heart if that feels okay. To just feel your heart. Just noticing how your heart's beating in this moment without any need to control it or do anything about it. Just be with it. And as you notice your heartbeats, notice your breath. Your breath and your heartbeats working in tandem. Just notice that rhythm and just be with it. Just let whatever happens happen. If the breath needs to expand or contract or become sharper or just be there where it is, just let it be. You may notice a sigh or a breath leaving your body or one part of your body relaxing. Or it's also okay to find yourself come out of this. Just go with it. Yeah, if it feels okay, you can gently tap on your heart. And as you slowly come back to the outside world, just bring your awareness to your feet, start wiggling your toes, feeling the ground beneath your feet, gently becoming aware of your neck and how your neck is holding your head. Take a few moments before you come back on to the outside world and look around you, the colors around. Before you come back to the slide to get more information. So this is what embodied self-awareness is. About perceiving movements, tiny movements like your heart, like wiggling your toes. We always start small. So wiggling, perceiving movements, registering textures and depth of the senses. So we didn't go into that as much because we don't have depth of time right now, but so we couldn't really engage in the depth, but exploring the intricacies of our emotions, not feelings, emotions. Feelings is the other subjective experience. So just the emotions. So this leads us to the capacity for interoception, which is part of the neuroception that was just named. So interoception is the capacity to read our internal world, to be able to pick up signals from our insides, heartbeat, muscles, etc., etc. So this interoceptive capacity is what we work a lot with in body psychotherapy. So what is the importance of this? This is fundamental in health and survival. Like I said, that the more aware, embodied awareness is there, the more self-regulation can be fostered, and therefore it will then support health and survival. Loss of embodied self-awareness can be debilitating. Embodied self-awareness is easily lost. I've already put a question mark there for you to think about. Why is it easily lost? If it's so critical for survival, why is it so easily lost? We'll come back to that in the Q&A section. So embodied self-awareness needs to be actively maintained because there are a lot of life experiences which take us away from embodied self-awareness. So it needs to be maintained, cultivated, and taught. So basic principles that we use, and you will see this across trauma modalities, you will see this across body psychotherapies. This particular word, resourcing, is met with very, very often, and especially if you're working with a phased approach to working with complex trauma and dissociation. So resourcing means getting the individual in touch with certain resources or certain external or internal, things, can be thoughts, can be images or anything, any structures, which helps them to come back to that place of okayness. So resourcing, slowing down and landing into the present moment, what you did right now, doing that with the client. So we don't teach this and ask them to do it outside the session. We do this in the session for that for their nervous system to feel co-regulated. Also, when this capacity comes in, then we start to ask clients to verbalize what they are experiencing. So we didn't do that right now, but if you were to sort of get into that verbalization, then you might wonder, you might put out a curious statement such as, I wonder if the sensation in your heart had a word, what might that be? So, in a very gentle, curious tone, you would put that. So, you're helping them to verbalize. We also, the golden question of where you feel that facilitates boundaries in the body schema that we have. Your body schema is represented in your homunculus. Remember that sensory motor cortex, may you have the representation of the entire body. So, when you ask that, we are actually fostering that kind of a naming of where we are feeling it in the body. And of course, self-regulation, re-engagement with active embodied self-awareness. Finally, when all of these are things that we have been able to do with our client, they develop the capacity to let go. Letting go is simply that ability to kind of come back to coherence, yes, from that space of hyperarousal. So body psychotherapy, this is a definition by the European Association for Body Psychotherapy. It is a distinct branch of psychotherapy, well within the main body of psychotherapy. So all that conceptualization of body psychotherapy as being pseudo psychotherapy does not really stand. So, which involves a different and explicit theory of mind-body functioning, which takes into account the complexity of the intersections and interactions between the mind and the body. So notice the next sentence, which says the common underlying assumption is that the body is the whole person and there is a functional unity between the body and the mind. Many other approaches in psychotherapy touch on this area. Body psychotherapy considers this as fundamental. So this body-mind unity is what we consider as a fundamental assumption. This is a whole history. We don't have the time to get into it. But body psychotherapy, especially dance movement therapy, is something that was, I don't know if you know this, but dance movement psychotherapy originated with the wives of psychoanalysts. So it's very interesting if you read the history of it. So this entire history, which is more than 1,000 years old now, is steeped in the tradition of working with fascia muscles. So that's the Alexander method and the Feldenkrais method, which works with something called Rolfing. So that's stimulating the fascia muscles to release any kind of trauma that is embodied in them. So much later, we have Wilhelm Reik's work, and then we have Ron Kurtz's Hakomi, and then one of Ron Kurtz's students, Pat Ogden, she conceptualized sensory motor psychotherapy. The 1990s were the decade of the brain, so a lot of theories in neuroscience actually helped shape this understanding. And we have a wonderful theory which is called way of working, which is Peter Levine's somatic experiencing. There are many others which are not named here. I don't need to remind you that I don't mean to disrespect those, but there are many to sort of name them here. So what are the principles? One of the most important principles, and Dr. Priya will also talk to you about it, that one of the most important principles of somatic psychotherapies is the concept of unity, which basically refers to an inclusive awareness of the interrelatedness of things. So that shift you felt between duality, from duality to unity, that's what we are talking about here, that it's not something two systems talking to each other, but it's really embedded together. Then comes the concept of organicity. Organicity is something which is unique in the concept of organicity and change. These two sort of work together. And because of paucity of time, I'll just explain both of these to you. Organicity and change believes that every organism has a way of resolving its own trauma. And the therapist's job is to hold space for that trauma to complete its life cycle, for that particular movement to complete its life cycle. How will that movement be? How will that movement complete its life cycle? What kind of arousal will be there? How will it get expressed? We wouldn't know that. And we have to go with it. We have to follow that. So when we say organicity, we mean this, that there is an organic way already that it can express itself, and it's going to be unique for every organism. So really respecting that, mind body holism and mindfulness. So mindfulness is quite literally the opposite of dissociation. The more dissociated people are, the less mindful they are. So as people are becoming more and more mindful, they will develop embodied self-awareness as well, which is the agent of change, as we saw. So these are some of the body-based psychotherapies. I have also listed out neurofeedback, HRV biofeedback, and other biofeedback also is working with the body because they work directly with the nervous system. Yeah. And of course, these are some of them: EMDR, internal family system, somatic therapy, which is child's work, Hakomi, sensory motor psychotherapy, somatic experiencing, biodynamic craniosacral therapy, body dynamics, and there's sensory motor arousal regulation therapy. So host of them, again, I haven't named a lot of them here. So many of these are not available in India as well. So abroad, there's a whole tradition, and a lot of clinical psychologists, licensed therapists also practice body-based psychotherapies. So the client's body is seen as a source of information about the client's state of being. Because as in working with complex trauma, we say you work with the state and the story changes. So the client's body sensations are a rich source of information for their state. So it's a repository for emotions and memories, which we discussed right at the beginning. It's an entry point for change. And also it's a vehicle for psychological intervention, significant as the mind and no different from the mind. And it's a source of somatic countertransference as well. Have you ever felt this, that after a session, if your client has said they feel a lump in the throat, and after the session you discover, why am I feeling a lump in the throat? So that's that limbic resonance and the somatic countertransference that you are sitting with. So I'd like you to think of this. Neelkant. So Shiva ingested the poison and therefore his throat is blue. Which part of you is blue? Because as you're working with clients, you're absorbing their secondary traumatic stress. You're also exposing yourself to different kinds of emotional vulnerabilities. Have you noticed which part of you, which body part, or which organ? For me, it's my voice. So which part of you is actually bearing the brunt of this work? Yeah, so sit with it. So that's what we are saying, that for each one, it can be a different system. So which system, and again, it can be about existing vulnerabilities. My throat had a vulnerability last year, so I'm still kind of getting over it. But each of us can have our own vulnerabilities, our own organs. Certain organ systems can have the inferiority that Adler talked about. So, where is it that we are actually storing that, the impact of it? And then we need to work with that. And I think we all will agree that in trauma work, especially in body psychotherapy, the work begins with the therapist's nervous system. You cannot enter the session not having worked with your nervous system. Why? Because the ability to co-regulate comes from your place of safety, your ventral vagal. So when you're stepping into the session, have you done the work to get yourself to a ventral vagal state? Yeah. So I'm going to stop on that note. You can scan this. This is another wonderful method called focusing, which was started by Eugene Gendlin. There are 6 steps. You can watch, there's a video on it as well. And you can do this on your own because you don't have the time right now. I wouldn't want to do injustice to this way of focusing and getting into your felt sense. Yeah? Yeah. So these are the 6 steps that you can refer to later on as well. This helps you to turn inwards and really land into your body and work with your felt sense. So this is the beginning. So let us start with the work on ourselves and then we can teach our clients how to go about it. So I will hand it over to Dr. Priya now and let her. Second step. All right. So thank you so much, Sukanya Di. That was, whenever I listen to her talk, I'm always really, I mean, it's so inspiring to see somebody so passionate about teaching trauma. She's, such an inspiration for all of us, for spreading this awareness, for making us more and more aware about why we need this kind of awareness. So she has, really built a very great background for us to maybe reflect on and given covered a lot of essential points. I will build up mostly on what she has already said. So the learning goals for my part would be assessing the body-mind association, and I am going to do it along with giving a brief overview of sensory motor psychotherapy. So I'm not going to separate these two, present these two separately. I'm going to help you all do the assessing body-mind association through the sensory motor psychotherapy lens. Okay. Now, Dr. Sukanya already mentioned, we know that implicit memories are harder to access and explain, right? Like, for example, if we meet a stranger and we haven't really spoken to them, but there's a felt sense of maybe something is not okay, I'm not feeling very comfortable. And if somebody asks us, we may share that इसके presence में ना अच्छा नहीं लग रहा है, and if somebody asks us क्या अच्छा नहीं लग रहा है, what is going to be the answer that mostly we're going to give? I don't know, पता नहीं, right? We may not exactly be able to pinpoint क्या अच्छा नहीं लग रहा है. Why? Because it's the nervous system that has detected something, maybe connected it with something that we have learned in the past, and there's like this whole thing that happens inside our body in just few seconds, and we're not able to really explain. So implicit memories are harder to access, thereby they're also harder to explain. And somatic memories are implicit, right? For example, let's say, okay,
So let's say somebody has had a car accident, all right? Like recently, this year beginning, I met with a deadly car accident. Now, since then, whenever I am in a car, I automatically find my body shrinking. If there's like even at 40 or 50 kmph, my body shrinks. Or if there's a car that is passing by, which is speeding, my body shrinks. Right? Why? Because it is implicitly stored in my body. It is not a conscious choice that I am making. It automatically happens. And it is so somatic memories are also impressive. They're difficult to access. Right? I am a trauma focused therapist, so I am still maybe a little more attuned and know a little more. But what about childhood memories? Right now, let's say you may hear clients saying things like, whenever somebody talks to me rudely, I develop a headache. Why do you develop a headache? I don't know. Right? Why? Because it is harder to access. There is something happening in the body, but what is it connected to? Why that particular thing is happening is harder to access. I'm experiencing bodily sensations. So one may experience bodily sensations, but may not really be able to give verbal reasons, right? Why this is happening, what else is coming up. They may not really be able to give a verbal explanation for that. So they may describe certain sensations and give I don't know why statements. Now, again, the outside conscious awareness and bodily responses also happen outside conscious awareness. It is not like we are choosing. Okay. Now, for example, let's say somebody maybe had a very difficult time during a particular time of the year. Okay, let's say during winter time they experienced something really disastrous, and the next winter they may experience some kind of a sensation in their body. Whenever that weather comes, their body automatically starts coming up with those memories. They are not consciously choosing it, that जब winter आएगा तब मैं sad feel करूंगी. No, it is not a conscious choice. It's happening automatically because the implicit memory is getting activated. And sometimes if the memory is really old, for example, whenever there is a spring season, I always think of my board exams. Because board exams used to happen around March. And every time it is February, March in Calcutta, that weather reminds me of my board exams. And it is not a conscious choice that I am making. So the therapist's task is to bring it to the fore by making the client aware of it. And this is a really heavy task because ये तो implicit है, उसको कैसे लेके आएंगे सामने, right? So that is something that we will have to slowly do, and this has to happen like Sukanya said, it has to happen gently, it has to happen really slowly. And for us to be able to do that, we need to be attuned to our bodies, we need to be attuned to them, and there's a lot of theoretical understanding also that we need to have, okay, about a lot of basic theories that whatever form of trauma focused therapy we practice, whatever, whether we are practicing sensory motor, somatic experiencing, IFS, some basics remain the same. Without those basics, none of these therapies can be practiced. Like polyvagal theory, window of tolerance, try-on brain, these things are the absolute basics of any school of trauma focused therapy. Okay, so I will talk something about something known as the core organizers. Okay, and as we go, you will see what I'm talking about. That how information is organized. All right, at the topmost level are our cognitions. What are our cognitions? Something that I can tell, right? I feel that I think I'm a loser, or it is so annoying that this person did not listen to me, right? This is the cognition, most easily accessible level. We can verbally describe the cognition. A little beneath that are our emotions. And this also can be verbally described. I feel sad. I don't feel okay. I think I I'm so happy that I got selected for the job that I was dreaming about. So cognitions and emotions are little at the surface, and most of our top-down psychotherapies work at this level. But there's so much happening beneath that, right? Like we just sort of discussed that the entire unconscious is somatic. Now, beneath that is the five sense perception. So, how do I deduce that I am feeling sad? How do I deduce? Maybe my energy levels are a little low, or maybe my shoulders are a little hunched, right? So, how do we deduce that? The five sense perception, what our sense organs are picking up, comes beneath that. The movement, urges, impulses. Okay. So, for example, as I am talking, I am also moving around. I am not talking like this, right? I am moving around. And this is happening automatically. This is not something that I am consciously doing. Or as I am talking, there is a gentle movement of my hand also that is happening. I did not plan and come that when I say this, I will make this kind of a gesture. So the bodily movement, the urges, the impulses are beneath that level. Okay, that is also, and again, these are not explicit. So जैसे जैसे हम नीचे जा रहे हैं हम और implicit में जाते जा रहे हैं. That is implicit. Okay, the movement, the urges, the impulses, right? And the bottommost level is the bodily sensation. What is happening inside the body? So the topmost levels are fairly easily accessible. If I ask somebody that what is happening with you right now, you may say that it's been a long day, I'm feeling quite tired, and I think I just want to go home and maybe take a rest, or I want to have a snack, right? But how do you deduce that? Okay, how do you deduce that? That deduction lies here, which is not really verbally, not easily describable, or not very easily accessible to our conscious brain. And now this client only can't access. How are we going to access? That is the role that a trauma focused therapist plays. That is where all our trauma therapy training comes in. Now, mindfulness and organization of experience. So, using mindfulness, we discover and change the organization of experience. Okay, and I'll a little bit elaborate on that. So, mindfulness, like Sukanya mentioned, this is the opposite of dissociation. What is dissociation? Not being connected is actually dissociation. In our textbooks, the way we read dissociation is much more than that. If you read the dissociative experiences scale, even tiny things, please रख के भूल गए, right? Or suddenly you're opening the bag and you're discovering, Hari, there is 5,000 rupees in the bag. ये कहाँ से है? You only kept it, but you forgot, right? So when they are not connected, dissociated, disassociated, not connected, and mindful is aware, attuned, right? So through mindfulness, we gather information in present time about the client's organization of awareness, client's organization of experience through mindful awareness of the core organizers. And I'll briefly talk about what exactly we do in that. And we focus on the client's body while actively listening to the narrative. So it is not like the narrative is less important. In trauma focused therapy, it is not like the narrative is not important. कि story सुन के क्या करना है? No. The narrative is important. We need to know, the narrative gives us the context, isn't it? So if the client is talking about a very difficult experience with their mother, and while talking about that, they're having a frown, we need to not just need to listen to what they are saying, we also need to notice their posture, their gesture, the prosody of their voice. Are they leaning forward? Are they leaning backward? Did they, like let's say the client said, I just told my mother to stop doing this, or I just want my mother to stop behaving like this. Okay, so there's a strong gesture. I just wanted to stop, right? So suddenly the volume is increasing and there's a strong gesture that is coming with it. And this is what the core organizers are. That this strong body movement and like a forward coming movement, protective hand gesture that is happening along with it. Okay, so there is a concept of dual awareness, right? I have to be aware, I have to listen to them. I don't want to invalidate them by not listening to them and only staring at their body. I have to listen to them. I have to listen to what they are saying because we will have to paraphrase, we'll have to link it to the bodily gestures also. So we cannot undermine the content. It is important. But we also should not get carried away with the content. But I am so engrossed in the content that I am not noticing any of the non-verbal aspects. Dual awareness. I have to notice their body, their posture, their gesture while also listening to what they are saying so that I'm able to build this connect. I'm able to bridge it together. So, in sensory motor psychotherapy, there are 5 steps to mindfulness that are enlisted. So, the first step is tracking. As we're listening to the client, we are also tracking them. What is tracking? Noticing, observing, right? Like, for example, if my client is saying that, yeah, I have recently got a new job, but I'm not too sure whether I want to join it. Okay. So I'm listening, but I'm also simultaneously observing. See, there's this movement. I'm not too sure. So the shoulders are going up. There's some kind of a head movement that is happening. Or maybe they're describing an experience and the facial expression is that of disgust. That how could somebody even do that? Right? There's so much here. It is not just a statement, how could somebody even do that? It is being said in a certain way, it is being given in a certain way. How could somebody even do that? The facial expression is saying something. Or tracking also becomes important when there is a mismatch. Yeah, I am happy. And this is such a dull I am happy. So is it really going together? It is not. And that's what we track. We are mindful, we are observing, we are very attuned to them. And with tracking, now what do we do with the information that we have tracked? We contact. What is contact? Matlab we tell them. We tell them that we have observed. Now we don't want to also put them under the spotlight and make them feel ki हाँ सब देख रही हूँ मैं. We don't want to do that. Okay. So we have to give them contact statements in a very gentle way. I see that as you're talking about it, there's a certain sense of tightness in your shoulders that I notice. So I have trapped that tightness in the shoulders. Now I'm contacting it. Okay. This is mindfulness. How will the client learn to become attuned to their body? These kind of steps. So when I highlight that, I tracked it. Something that the client was not aware of. Maybe the client was, really hunching their shoulders. So I tracked that. I noticed that. And I contacted it. I highlighted that, hey, I noticed that, as you're talking about this, the shoulders are looking really tense. So when I contact that, what is happening? What is going to happen? They're going to become aware, right? So they were not aware before that. Now they are becoming aware. So I am trying to make them a little mindful of that. Okay. So what is going to happen then? Either they're going to acknowledge, yeah, you're right, and maybe a change might happen, right? They may drop and relax. Or maybe they may deny. No, I don't feel any tightness. Now the task of the therapist is not to prove कि नहीं मैं सही हूँ. I am trained in sensory motor psychotherapy. I am telling you your shoulders are tense. No, that is not my job. I am not a lie detector, or I am not a detective or a judge or a lawyer over here that I have to prove something. All right. Okay. All right. Is there something else that you notice in your body? Or, so our task is to go with the client. If the client says that you don't notice that, fine. Okay. So it is not about the hierarchy. I am your therapist. I am right. It's not anything to do with that. All right. So if they say that is not what they feel, we acknowledge that, we accept that, and then we also, then maybe, we don't have to force them, force what we have observed of them. After we track and contact, okay, so I have tracked that the shoulders are tense, I have contacted, that means I have verbalized that. What do we do? Something known as mindfulness directive. So I mindfully direct their attention to that. You just want to notice that, right? So the task, why did I contact? Because I want them to be aware. I want them to stay with it. Okay, so they become, so mindfulness directive is whether mindfully direct their attention to that. I ask them to stay with that. Can you stay with that? Okay, or maybe if the client is maybe maybe I contact the, let's say, disgust expression on their face, and I ask them to stay with that. So that is to create space for that. We don't want to rush into change. We want them to be aware of what is happening in their body, and that is where all the in-depth work will happen. Okay, so mindfulness directive, asking them to stay with it. Notice that. Notice that. Can you just stay with that? Okay. Then mindfulness question. So mindfulness question can, be so many things. For example, as you notice the hunched. So in mindfulness directive, I ask them to notice that. And now in mindfulness question, I ask them, let's say, if the tightness in your shoulders had a voice, what would it say? Or are there any words that go with that? Or as you notice the tightness in the shoulders, what is happening? So I am mindfully asking a question. And based on my mindfulness question, I obtain a mindfulness report. All right. What is a mindfulness report? What the client is sharing with me. That, let's say, so when I was talking about a lump in the throat, okay, so let's say the client is talking about a very difficult interaction with their mother, and I noticed that their voice has started breaking. So I track that, I contact it, but I hear that as you're talking about it, a voice suddenly has started breaking. So I contact that. And then I ask them to stay with that. Maybe they report that I feel a lump in my throat. I ask them to stay with that. And then the mindfulness question is, what would the lump say? Or as you notice the lump, what happens? It depends upon your intuitiveness and depends upon, how you are connecting with the client. Depends upon how do you think that the client is somebody who will be able to give you a good mindfulness report, or are they at the preliminary stages? So depending on that, you frame your question and then you obtain a mindfulness report. So once you ask the mindfulness question, what if the lump in your throat could say something, what would it say? So what the client tells you is the mindfulness report. That it would say that it's enough, I can't do it anymore. Whatever the client says, okay? So these are the steps to mindfulness. But we are very mindfully trying to notice the core organizers. We pick one of the core organizers, one of the experiences, and like Suganya said, we use it as an entry point. Okay, it is all implicit. So we need an entry point. How do we access it otherwise? Now, it's, of course, there's a lot of this work that is going to happen in the session, but eventually it is also about making them aware of their own mind-body connection, right? Because sessions are happening once a week, or let's say if the client is more distressed, maybe twice a week. But we're not meeting them every day, we're not with them all the time, but we want them to slowly develop this awareness. So what do we do to help them develop this awareness? This whole mindfulness report, this whole practice that I just explained, one is we do that repeatedly with the client, and it is not a technique, this is a process. It just happens in an inbuilt way. Okay, it is not like हाँ एक बार कर लिया खत्म. It doesn't happen like that. We keep doing the tracking, contacting, but we also don't overdo it. We don't want for example, in one of the so when we are doing any of these trauma focused therapies, usually we are broken down into breakout rooms. I'm doing an online training in sensory motor psychotherapy, and our as a part of the training, we were broken down into groups of 2, and we were practicing. So my colleague with whom I was practicing, so when we were doing the work, it sort of a very difficult memory came up for me, and I sort of got a little carried away and broke down. Now my colleague is also just learning. I am also just learning, and we're just like sort of trying to utilize the skills that we have learned. And while crying, there was a point when I placed my hand over the chest, and then I was breathing and hyperventilating, etc. And my colleague sort of was trying to track contact and do this entire 5 steps to mindfulness. But in the process, I felt over contacted. Okay, in the sense that, oh, now I can see that your hand is going to your chest. I can see that you're, sighing, or I can see that your voice is breaking. And then towards the end, when we do feedback and we discuss how it went, etc., we sort of discussed that I felt. Now again, I am a different individual. Somebody else may feel a different way. I felt a little over contacted. That every single thing is being noticed. And this 5 steps to mindfulness doesn't always have to happen verbally, that I'm telling them. I may also mirror their gesture. Or if they place their hand over their heart, I may also place my hand over my heart. Okay, so we can also do some non-verbal mirroring of some gestures, whatever is appropriate and whatever is within the ethical limits. Okay. Now, how do we make them aware of the mind-body connection? One of the very useful things, other than the 5 steps to mindfulness that we will keep doing with the clients, one of the very useful things is psycho-educating the clients about what? So we introduce the window of tolerance, we talk to them about the window of tolerance, we explain, we help them understand what does their hyperarousal what their hyperarousal may look like, what their hypoarousal may look like, what are their triggers. So we make them aware. And the utility of this is also that they get terms, they get labels, they become aware, and they are able to use this outside of the session. So outside of the session, they have some kit in the sense like their own skill set, little bit they're developing, right? We may ask them to, we may talk to them about the window of tolerance, ask them to maybe notice outside of the session, but okay, maybe can you just maybe, and again, in trauma focused therapy, we don't give home tasks as ki karna padega. Okay. It is something that you may, it's always about choice. We always give them that agency that, do you want to try this? Or maybe you could, right? We don't say it like, मतलब अब यही है, आपने home task नहीं किया, अब तो आपकी therapy नहीं हो सकती. That is not the idea. Because we don't want to come across as authority figures. I know everything and I am going to do something to erase all the symptoms. No, that is not our agenda. So we have to go very gently. Now there are some clients who are very, how do I put it? Well read. There are some clients who are themselves very psychologically minded in the sense that they may have done their own little bit of reading. So then we can utilize that. We can maybe, use that as a resource that they like reading. Okay, so that in itself can be a resource. And we can explain some of these things. Okay, so these things, they are also very depathologizing. The client feels very depathologized because now they understand their symptoms. Now they understand that why they are procrastinating or why they are feeling a certain thing, right? It is a lot, all of this neurobiology of trauma and talking about attachment, etc. It gives them that compassion that nothing is wrong with me. Okay. We talk to them about the polyvagal theory. We give some home tasks. So this psychoeducating bit also helps them to be aware. Sometimes a little bit when we have progressed significantly into the therapy and we have done a lot of this 5 steps to mindfulness repeatedly with the client, you may notice that the clients are themselves able to say that, as I am talking to you about how my dad yelled at me, I can feel that my calf muscles are tightening and I just probably feel like running away. So when that awareness builds, they will themselves be able to give you a mindfulness report. They will themselves be able to resource their own selves using different somatic things. Now, how do we, and I'm just, going to wrap up in a bit. All right. So, when we are working with the body, there are a few things, a few principles, or a few, like a framework that we have to keep in mind. Okay? We cannot work with the body without really keeping this in mind. One is that we have to be observing and we have to be attuned. All right. Attuned towards what? Only attuned to what they are saying or expressing. Attuned to ourselves also. So that's where the dual awareness also kicks in, right? Where, so Kanya mentioned that when the client is explaining something, maybe they are experiencing a lump in the throat, and you are also probably coincidentally experiencing a lump in your throat. Okay, like I have noticed that with certain clients, I tend to lean forward, and with certain clients, I find myself leaning backward. Okay, so that means there is something happening, and I need to be attuned to that as well. Or sometimes I notice that while maybe having a session, if I'm explaining something, sometimes I notice that suddenly my speed increases, of my speed of talking, it increases, and my voice becomes a little shrill. Shrill as in not like I'm screaming, but the pitch sort of goes up. Okay, and maybe some shift has happened in my body. So I have to recalibrate. We have to be attuned to our own selves. So I might have to recalibrate, maybe because if my client is anxious and if my speed has also increased and my pitch has also sharpened, my client might become more anxious. So I have to now be attuned to my body, be attuned to myself, and mindfully bring it down. Right? Mindfully slow it down a bit, bring down the pitch. So this attunement has to happen in here because it's not just that they're only getting co-regulated with us, we are also getting co-regulated. We also have a nervous system, right? So our nervous system is also picking up on that, on the cues of their nervous system. Their nervous system is picking up on the cues of our nervous system. But we are the therapist in the room. So we have to be attuned. We have to be mindful. We have to not just be mindful and attuned to them, but be mindful and attuned to ourselves. For example, if you are feeling very unwell and entering a session, that's not really a very great idea because you yourself are at the edge of your window of tolerance. Okay, so you'll not be able to be fully present for the client, isn't it? You might not be fully attuned to the client. So maybe before entering the session, doing some self-regulation, doing some little bit of regulation work with your own self to bring yourself back into a somewhat optimal level of arousal would be a useful thing. Because when we are in our ventral vagal, when we are in our optimal arousal zone, is when we will be able to connect to them, be attuned to them, observe them. Isn't it? If I am myself, let's say, having a very bad headache, how will I be able to observe their non-verbal? Now, we have to then identify a particular core organizer to enter the realm of the body. So, we are talking about a particular core organizer. I told you about 5 core organizers: cognition, emotion, 5 senses, movement, and bodily sensation. So, now a particular memory is going to have all the core organizers activated. Okay. Now, for example, if I ask you to think about a pleasant holiday, most recent pleasant holiday, all your 5 core organizers are going to get activated. If I really, take you inside the memory, you will have some thoughts about it, that it was a very lovely holiday. I wish to have more of that. There'll be some emotions, there'll be some bodily sensations, maybe there'll be some movement, like you may want to do a self hug or something, right? 5 sense perception will get activated. Maybe you're able to smell the breeze or feel the warmth on your skin. So पांचों यूज करके एंटर नहीं कर सकते. We will have to identify one. That can we just focus on this sensation in your chest? Or would it be okay for us to maybe just notice the tightness you are experiencing in your shoulder? Okay, just identifying one core organizer to enter, because we have to enter. I can't enter this seminar room from this door and that door simultaneously. I will be able to enter only from one door. Now, which door I have to choose depending upon whichever is most easily accessible. So, if a client is recalling a particular memory and there is a lot of activation, they are saying lump भी हो रहा है throat में, crown भी हो रहा है, tightness भी हो रही है, chest is also getting heavy. We can't enter through all the entry points. We may have to enter through one, that which out of these stands out the most. Or we can also see that or we are probably seeing that they are really hyperventilating, something which is like really standing out. So we may suggest that would it be okay to notice this, or like just one particular core organizer. Why? Because we want to enter, we want that laser focus into the memory or into the experience. And then 5 steps to mindfulness, we deepen the connection by asking mindfulness questions. Now, this thing is applicable in all the stages of trauma focused psychotherapy, whether we are doing stabilization. So, in order to stabilize, also we have to do this. Whether we are doing processing, for that also we have to follow this. These are the basics. So we deepen the connection by asking mindfulness questions. We ask them to stay with it. We ask them to notice what's happening as they're staying with it. So we deepen it, right? Why deepen? Because we don't want to touch base. Okay? We really want to stay with it. We want to make space for that. We want to emphasize on how important it is. And then we can try somatic experiments depending on what we are trying to do. If we are trying to build a resource, then the kind of somatic experiments will differ. If we are trying to do processing, the kind of somatic experiments will differ, right? But this is the basic framework of working with the body. Now, I would just like to wind up by saying that trauma recovery involves re-establishing a sense of agency, control, and trust in the body. That is what they have lost, right? They aren't connected to their body. So when we are talking about trauma recovery cannot happen without taking the body into consideration. It cannot happen by just asking the person to think in a different way. We have to acknowledge that there is something much deeper than that. Okay, so that's what I wind up with. Thank you so much, everyone, for patient listening. Hello? Is it working? It is.
Thank you, Dr. Sukanya. Thank you, Dr. Priya. It was a wonderful workshop. I wish we had like few more hours in hand. So when I was going through your presentation, something clicked about my own self. So it was Diwali party, and it was 11 o'clock when I reached home. And it's like at 10:45 or something, one of my friends who used I did MPhil from this institute. She did a PhD. So I left when she joined, and she told me about someone I was kind of closely related to when I was doing my MPhil there, and something bad that had happened in their life. And it was 11 when I reached home. I couldn't sleep till 2 because it was just going on in my head. I was going through a Facebook, what's happening in her life, and number of things. I was then scrolling reels, but couldn't fall asleep. Then I got, Preeti, what are you doing? Come back to your body. Just see what's happening. I won't lie. I just sat with my body for like 2-3 minutes. I could connect with that disturbance. I sneezed and yawned. Within 15 minutes, I could sleep. That's the power of body. I said buttons are all within us. So yes, I mean, wonderful. And thank you so much for taking us through this. Particularly as a clinical psychologist, I do struggle with people who have disconnect with their body. And I think I got immense ideas, and like the amount of patience one has to have when they are working and the attunement.
that one has to have with their self, with the client, everything all together. So thank you. Thank you so much for it.
Thank you so much, Pamela.